Good morning, everyone. The time being 10 a.m., I'd like to welcome everyone to the Special Committee on COVID Response Efficacy, and I'd like to ask Representative Polozov to lead us in the pledge. I'd like to remind everyone that this is a bipartisan committee tasked with investigating and evaluating the state's response to the COVID-19 pandemic. The committee will function in a science-based, fact-finding review, specifically acquiring comprehensive, accurate data and all related information pertaining thereto. Areas of particular focus will include the administration of federal guidance, acceptance of federal funds, and implementation of emergency use authorization vaccination efforts. A report will be issued outlining the committee's findings and the impact on New Hampshire. And this morning we have Dr. Jordan Vaughn here, and I would like to welcome Dr. Vaughn. And would you tell us a little bit about yourself, where you're from, and anything else you would like to say?
Yeah, my name is Jordan Vaughn. I'm actually an internist that practices in Birmingham, Alabama. I am trained as an engineer previously. My undergrad is in engineering, and then after that went to med school at the University of Alabama, Birmingham, and then actually did my residency there. I am additionally the son of a physician who was also a general practitioner. I am uniquely a private practitioner, somebody that actually basically has his own organization and is responsible for about 200 employees. We take care of about 150,000 patient visits a year. And that was some of the unique aspects of what I'm kind of tasked with learning a little about, was how to take care of not only my employees in this, the last 4 years, but also how to make sure that my patients, whether healthy or with chronic conditions, were also taken care of. And so that's a lot of where my expertise came from, was just really trying to find solutions.
Does anyone on the committee have any questions for Dr. Vaughn? Or, well, I have one. And just chatting with you this morning, you were letting me know that you were being contacted by a physician in New Hampshire.
Yes.
And so your practice and you personally help people across the country, is that correct?
That's correct. So throughout this, I actually kind of acquired a specialty looking at COVID-associated coagulopathy and microvascular disease. So what we do know about the spike protein is that it is highly coagulopathic, that it causes fibrin to form in abnormal ways that are harder to break down. So imagine that fibrin is kind of like spaghetti that just came out of the colander that you can kind of break apart. It's involved in you making clots, but the spike protein is able to make fibrin more of like a burnt spaghetti casserole that's stuck to the bottom of a casserole dish that requires a Brillo pad to get rid of. And so in many ways, working with some folks in South Africa, as well as University of Liverpool in England, we have kind of a consortium of understanding the concept of microvascular coagulation issues in COVID and vaccine injury. And so uniquely, obviously, the vaccine produces spike protein, and spike protein can do this independent of thrombin. Thrombin is usually what's required to make clots. Additionally, the damage to the inside of the vessels, which is what we call the endothelium, causes a lot of damage too. So you can get a lot of microvascular issues that don't necessarily show up in a typical cardiological exam or somebody that's being treated for coronary disease. So in a lot of ways, what I treat is getting a lot of my patients are very young, athletic people historically, that after either COVID or the vaccine, now are almost to the point that they're bedbound. And a lot of getting those kids back to normal has been, how do we heal the vasculature back to the level that the vasculature is working properly? So the cardiologist that reached out this week is from New Hampshire, but I'd been taking care of a patient that had come down and been evaluated and treated, and he was just interested that he had gotten better, and he had another patient that very similar that he wanted to kind of have a talk with about.
Great. Representative Wary?
Yes, thank you, Madam Chair, and thank you, Dr. Vaughn, for taking my question. Is this related to the myocardial effects that we're seeing in young male population right now? We've seen where, anecdotally, there are people who are uh, keeling over on athletic fields. We're also seeing situations where they've now recognized this as a formal side effect in a large population that's received the vaccine. Is this related to those incidents?
It is specifically, there's a most recent journal looking at the vaccine injuries in myocarditis, and they compared it to a cohort of adolescent males from the age of 15 to 17. And interestingly enough, the myocarditis only occurred in those that received the vaccine. So it seems like the myocardial dysfunction definitely is more related to probably the product itself than actually COVID. But COVID, because of the spike protein, also is just, I've got probably 15% of my patients that are debilitated that never had the vaccine either.
Follow up?
So do you suspect that because there's a transmissibility with the spike protein vaccine, or?
We don't really know, but I will say that the spike protein itself, regardless of its source, is damaging to the vessels and causes coagulation issues in people. The other thing that we've kind of looked at is a lot of these people already had some predispositions for clotting, but those predispositions were nothing they knew about until after the fact. And so again, it's some of the things that we've kind of realized is there are people that are more prone to injury, but those aren't things that we would have probably never investigated previously. And so then we find that out afterwards. It's nice to know it, but it doesn't change the fact that we've got to get them better.
Representative Belcher?
Thank you, Madam Chair, and thank you, Dr. Vaughn, for being here. So I guess my question is, I'm not even sure if you can answer this, but if the spike protein is perhaps cardiotoxic and certainly toxic to vascular material, is this something that could or should have been known prior to using the spike protein to develop the vaccines on?
Yeah, that was, let me go through a little bit of my testimony in that regard, but kind of just starting from that. But what I would tell you is I'm, again, outpatient clinician. 2020 presented kind of a broad set of challenges given the fact that I've got to take care of both my employees and then 150,000 patients that kind of seek my business for care. But as I kind of went into the literature and tried to find the best understanding of SARS-CoV-2, the spike protein as well, what really emerged was the spike protein was all of the above. It was immunotoxic, cytotoxic, coagulopathic, and unfortunately also amyloidogenic. And so it was interesting to me, and one of the big things that I had an issue with when the vaccine was brought into the forefront, a little unknown to me as my patients who I already knew started showing up with shortness of breath or other kind of side effects following the vaccine, then they would also have abnormal clotting issues like D-dimers that were elevated. But at the same time, I wouldn't see anything when I would get imaging to find out if they had big pulmonary embolisms or anything like that. But I would treat them as if they did and they would improve. And that kind of led me down the pathway trying to understand the coagulation aspects of that spike protein. But the truth is we did. The spike protein itself, we know, has been coagulopathic. And then in addition, if we didn't know by the time that the vaccine was rolled out, we would know then. I mean, basically, when we look back at March 2020, the people that I work with in South Africa, one of them named Jocko Lobsher, who's a cardiac intensivist in South Africa, he actually released a video back in June of 2020 that basically said, we're barking up the wrong tree. This is not a respiratory disease per se. It's a vascular disease. That's where it's causing the damage. And that's really why a lot of times even putting people on ventilators was the exact opposite of what we would want to do. If you have a pulmonary vascular issue, limiting the blood flow to the lungs, causing lower oxygen levels, the worst thing you can usually do is increase the intrathoracic pressure and close down more vessels. So a lot of what I did in acute COVID was basically getting patients diagnosed, treated with early treatment, and also getting them on things like anticoagulation and antiplatelets, getting them on home oxygen, and then for the most part, getting them better. I actually had to kind of develop my own what I would call oxygen angel. One of the patients that I had treated her husband, we had pulled him out of the hospital and put him on home oxygen, got him on anticoagulants. And then she started to say, it's kind of hard to get oxygen. And so we came up with the idea of her kind of traveling around to all these patients that might need it after they had seen me. And she delivered the home oxygen to them. And we were able to actually treat about 500 patients in the outpatient setting without actually having them admitted to the hospital. And all of them got better.
Representative Polozov?
Thank you. Thank you for your testimony. Could you clarify what's the difference between home oxygen and putting on ventilator?
So a ventilator. So when we breathe, for the most part, it's a negative pressure, meaning like your diaphragm basically contracts. It creates a negative pressure, and you bring air into your lungs. Okay. When you're on a ventilator, that's what we call positive pressure ventilation. You're basically forcing more air, increasing the intrathoracic pressure. Problem with that is that's not how we're designed to breathe. And if you do that for long, you damage the lungs regardless, if that makes sense. And so if you can, what we were able to do was make sure they had adequate additional oxygen without limiting the continued availability of the vasculature that actually was still useful. And so basically, again, home oxygen was putting them nasal cannula or high flow where they were still utilizing their diaphragm to bring air in and out, not having air punched into their lungs like you would in an ICU.
Follow up?
You also mentioned four properties, known properties of spike protein: immunotoxic, cytotoxic, coagulopathic. Could you repeat the fourth property and what it means?
Amyloidogenic. So that means that the spike protein itself can confer other proteins to abnormally turn into different shapes. We call it amyloidogenic. I mean, the kind of classic disease we typically think about is a prion disease like CJD. But basically, it's an interesting thing that we find in medicine that a certain conformation of a protein can cause other proteins to conform to it and without another, what we would call enzymatic activity. And that's a very dangerous thing. We don't like that. That's actually, when you think about amyloidogenic, you're thinking about all the diseases you don't want when you get older.
Representative Belcher?
Thank you, Madam Chair. And just to follow up a little bit on the topic of ventilation, I'm no physician, but I do have a little bit of a background in healthcare. From my time as a paramedic, I was aware that we typically try not to intubate and ventilate if we don't have to because it can be damaging. It seemed to me at the time, early COVID, that the rather aggressive use of ventilation was abnormal. Throughout our investigation as a committee, we have seemed to find that the source of these protocols may have been through the World Health Organization, coming down from the WHO to the CDC, NIH, and from there. Do you have any information about where these ventilator protocols came from and whether you found them strange?
Most of them, I felt like, came from Health and Human Services in the NIH. But I will say that no one's name was attached, nor was there any documents supporting such things. And in fact, most of the hospitals would tell you that even the protocol for treatment might have even come from the CARES Act, a legislative document that was passed in what was actually reimbursed for care based on how people were treated. And that's an interesting thing to find in its own right. The other thing early on, I think again, going back to something we have talked about it, is fear. There was fear that if you could intubate the patient, that you could close the loop and actually not have exposure to other people in the hospital to actually getting COVID. Now, that's kind of a foolhardy thing in itself, but I think some of the people, that was more, initially when you talk to ICU doctors, that was some of their thinking was, hey, this person has active COVID, to keep them alive, let's close the respiratory loop to make sure that it's not exposing other patients. Now, was that the correct thing to do? Again, we could debate that, but I think that there was some fear around it. If I'm going to take care of that patient, I want them on a different breathing loop than my loop.
So I'm just wondering about the timeline here. When did you discover, because COVID, we all know that the shutdown happened in 2020, March of 2020. was when we started seeing an increase in cases in the U.S. New Hampshire shut down just before St. Patty's Day. So when we're talking about the ventilators, when were you aware that that was not a proper use? And how did you find that out, I guess is my question, and why wasn't that knowledge widespread?
So it was by that summer we understood. So summer of 2020. Again, one of the great things that NIH and National Libraries of Medicine have done is make it available to read what the rest of the world is doing. Okay. And so if you were actually diving into the literature and seeing what South Africa was doing, what Italy was doing, what England was doing, you were able to see that people were trying different things and they had different results. And when those results were positive and counter to what you were told, that was when you started going, there must be something here. So it was about that summer that most people realized that the ventilators were even at best a salvage, and it wasn't the correct way to treat things. And again, I would say I kind of laud Jocko Lobscher, cardiac intensivist, very independent person in Stellenbosch University in South Africa, who basically said, look, we need to stop putting people on ventilators. The problem was by that time, the legislation that the government had put out had kind of codified treatment as well as payment for treatment. And that actually probably changed the incentive structures for taking care of patients in the hospital with COVID.
So let me understand this correctly. So what you're saying is that the knowledge out there that ventilators were not the way to go, because this was not really a respiratory issue.
Well, yeah, it affects the lungs, but it doesn't affect the airway of the lungs.
Right, the airway of the lungs, okay, in summer of 2020. But legislation in the way people were paid for treatment meant that they still had to follow a protocol that was actually doing harm. So I guess my question is we have doctors in hospitals that have access to the information on what's working, what's not working, the same as you did, but are choosing to follow a protocol because of non-medical professionals and dollars.
Most likely. I don't question that the doctors were trying to do the best that they could, and based on the protocol, that's what they were trying to do. I don't think sometimes as a physician, you have the flexibility, or a lot of physicians don't even have the curiosity anymore to think that maybe what they're doing, since it's not working, may not be the right thing. And so it is true. I mean, I think what I had found, and even at my state level, had to meet with the board with, was that I would pull somebody out of the hospital. Well, first of all, the patient themselves was not even really visited by the physician. They were visited on the phone. They were chastised. They were basically put in isolation. And so to me, made no sense for, even if he was going to pass away, why were we doing it under the conditions of him being in solitary confinement? So instead, my knowledge base, as well as understanding of the disease process, gave me the freedom as well as the knowledge base to say, no, let's do something different. And when we started doing something different, it worked. And that's, again, what Jocko was doing in South Africa. They started doing in a lot of other places where they had realized that ventilators were not the solution.
Representative Belcher.
Thank you, Madam Chair. So what you've just suggested to us regarding the codification of care within the CARES Act really tracks with some of the other information we've received and some of the other bigger trends we've seen, especially with things like the long-standing delegated authority of physicians to prescribe off-label that was suddenly removed for a number of medications during the pandemic period. So I guess my question would be, do you believe that there was, amongst all the fear of the pandemic, an effort to central plan healthcare that ultimately had, detrimental effects?
Yeah, I definitely think the deferral to your octogenarian in Washington who hadn't treated a patient in 30 years was probably not the best way to treat a new disease process. And I definitely think also that Most of the time in medicine, and this is probably more of more of a historical view, but most of the time, very little is discovered within the confines of the ivory towers. They're very good at improving technical expertise, safety, the ability to do things. But when a new disease or something like that comes along, it usually is somebody outside the system that figures out that the way to treat it. Because again, usually a new disease or a new process requires a rethinking of how we have treated something in the past.
I'm trying to wrap my head around all of this because I'm not being in the medical profession. So, do you, I know you're an internist, so I'm just going to throw this out there. We heard testimony in our committee about masking. And are you seeing within your patients any detrimental effects from people being forced to wear masks? Or, and the other question would be is, we also understand that the virus was, I forget what it was, 0.05 microns, so that even those cloth masks, it could penetrate through. So they really weren't stopping the transmission or the receiving of COVID, is my understanding. If I'm wrong, please correct me. Do you know when we knew about that science?
Yeah, it was actually in 2019, there was a study done in a hospital setting assessing surgical mask and N95 mask on the flu. And actually, this was published in, I think, the New England Journal. I'll have to give it to you at the end of this. But what they found is there was no difference. And then that actually was a follow-up study to something they had done 2 years before, looking at whether surgical masks changed the dynamics of a flu in a hospital. And again, we're talking about probably the best case scenario for running a study like that, having healthcare workers wear a mask properly, wear it in that context. And again, both studies showed no effect. And so that was really, again, what was so contrary to what was just published 6 months before the outbreak, that it, all of a sudden was, well, this is the way to go. And even in Tony Fauci's emails, when you look at them now, he was commenting on it before he changed his mind, that based on the data that we had years and years and years of information. Now, it's hard to do a mask study. And I would actually argue that probably most mask studies have plenty of confounders, plenty of fallacies. I mean, it's just very, very hard to do a behavioral study like that. So since then, there's been studies on both sides. But it's, again, I think the common knowledge was exactly what you're saying. It was ineffective.
Representative Belcher?
Thank you, Madam Chair. And continuing on that same sort of line of thought around masking, we've heard from our public health officials that they pursued what they call a Swiss cheese approach to trying to mitigate the spread of the virus. And I think what they mean by that is Swiss cheese has holes in it, but if you stack enough layers of Swiss cheese, you can cover all the holes up. So I'm wondering, do you find that to be an appropriate analogy to those kind of public health policies, such that when you stack masking and social distancing and these other things together, they necessarily have an additive effect rather than something else?
I don't think we know. I think your intuition would say maybe, but oftentimes in medicine as well as science, intuition is not always the answer.
Representative Weary?
Thank you, Madam Chair. Thank you, Dr. Bond. I'd like to go back a little bit to the incidence of what you're seeing in the coagulation aspects. And we've heard anecdotally that funeral home directors and autopsy results have found in looking at people who have passed away, that there's an unusual clotting and coagulation that's going on in those individuals. Do you have any knowledge, or does this relate? If so, does this relate to what you were talking about in terms of the coagulation effects that you're seeing?
So the quick answer is, obviously in my world, it's a living tissue. It is interesting, and I've actually talked with some of the funeral directors, and actually in my lab I have not actually done my specimen analysis of them. But one of the things we're trying to figure out is what is the content of them, because the content would be very helpful. Does it have a lot of the same properties of the clotting that I'm seeing at the microscopic level, so in the microclotting level? But it is the same kind of thing that we're seeing in the living in terms of these, vascular and coagulation abnormalities. And then the way the clot is formed in these people is very different than what we had normally seen. So when you compare it to something that's not related to COVID, a clot or a thrombus, these thrombuses are much harder to break down. They're different in kind.
Follow up?
Could you expand on the different in kind? What do you mean by that? That's
So,
interesting.
I mean, a lot of it has to do with at the protein level, how proteins come together. And so in truth, our body's designed to basically clot when it needs to clot. But when it's done clotting, or actually those vessels need to be opened up, those things need to be able to be broken down fairly easily. We call that fibrinolysis, the ability to break down fibrin. And so what we have found is that the spike protein causes conformation of the fibrin into a way that's resistant to fibrinolysis. So the body is not able to break it down. And especially in people that already have some genetic predisposition to fibrinolytic issues, meaning they don't break stuff down to begin with, it's kind of a cumulative effect that even compounds. So all of a sudden these people are having, DVTs, pulmonary embolisms, coronary thrombuses, strokes, all of those kind of things. And all of those, the incidence of all of those is on the rise. And, again, you could make some arguments, again, that's just a correlation, but just in our research, it seems like there's a pretty good, and it's starting to even come out in the literature, that post-COVID, and again, most of the time now, most of the research is looking at post-COVID, which usually for a huge percent of the population would be post-COVID, post-vaccine, that the incidence and issues that are associated with coronary disease, heart failure, those kind of things are changing in a negative way.
Representative Belcher?
Thank you, Madam Chair. And again, to stay on the same line of thought regarding clotting, which is very interesting to me. I don't know the linkage between what was talked about with the cadavers versus this microclotting you're talking about. But I always have been a bit of a natural skeptic. And if I hadn't been one of those people who was in the immediate aftermath of vaccination, I had a whole host of health problems, a lot of issues. I deteriorated for a period of several weeks before I was ultimately hospitalized for almost a week. And after taking my blood, the very first thing they did to me was shoot me up full of heparin.
Yep.
Because I was having abnormal clotting. Only time in my entire life I have ever had a blood test demonstrate abnormal clotting. So my question would be, do you know how common that phenomenon of coagulopathy was, either both post-vaccination and post-COVID within the population?
So the interesting thing about the studies is basically we know that everyone that gets vaccinated or has COVID exposure to the spike protein is going to make this abnormal fibrin. And that is bad. The question is who can get rid of it and how much do you make? And those really determine what I would call the symptoms and the downstream effects of whether being vaccinated or having COVID. So again, going back to this barking up the wrong tree, it's not a respiratory disease, it's a vascular disease, it's a vascular phenomenon. That's basically what you're provoking. And so again, what we have found and are still trying to find is what actually makes a person more susceptible to this. But in my research, as well as my taking care of these patients, the less spike, the better.
Representative Wary?
It's just to follow up on that, with that abnormal clotting, and we talked a little bit about this before the meeting formally began, but what sort of treatments, as an internist treating your patients, what sort of treatments are you looking at to counteract this abnormal clotting that you're seeing?
So early on in the pandemic, or in basically the outbreak in the spring of 2020, one of the things that was interesting, if you looked at the data of people that were hospitalized and people that actually left the hospital after being hospitalized, is there was, from especially some of the New York hospitals, and I'll get you the paper, it was twice as likely that you were to leave the hospital alive, and again, these were mainly older people at the time, if you were on a blood thinner. Well, people that are on blood thinners from a morbidity standpoint aren't healthier than people that aren't. So why is there a selective advantage to them being on blood thinners? And it was actually, that was probably some of the first suggestion that there's something here. And so when we think about how we have treated acute COVID, and that was under the, really the science of Jacques Lobsher as a cardiac intensivist, working with Risha Pretorius, who's taught me how to utilize immunofluorescent microscopy and look at blood. They were able to look at patients in the hospital, in the cardiac intensive care unit, and find that they all had these amyloid fibrin findings, and they were able to see, after they put them on anticoagulation and antiplatelet therapy, that those things got better, but so did the patient. Does that make sense? So that was the first clue that treatment with that was effective. Now, move that forward as patients started to show up in the offices of Jacques Lobsher and me, who had survived COVID or had some type of vaccine injury, and were complaining of similar symptoms, not to the extent that they needed to be hospitalized. But when we looked at their blood, they had similar findings to what Jacques was seeing in the CCU. And so it made kind of intuitive sense to say, hey, if the treatment worked for these people, can it work for the patients that are in the outpatient setting? And so that was our first kind of move into it. And so Jacques published a case load of probably about 60 patients that he tried antiplatelet and anticoagulant therapy on. And between us, I've probably treated 2,500 patients now with dual antiplatelet and anticoagulant therapy, and had really, probably success in the 70% in terms of returning to normal status. Now, everyone's different. Not every bit of long COVID or even how COVID attacks the body is all vascular. The immune system is still involved a lot. So there's lots of autoimmune things that can go on. But the thing that we have learned is that you can't disambiguate or disentangle the inflammatory system from the coagulation system. In fact, what we call it is thromboinflammation. You'll probably, the next 10 years in medicine, you'll hear that word a lot, because thromboinflammation, especially of the microvasculature, is responsible for a lot of other diseases that we talk about, like dementia, like different, coronary microvascular disease, other things like that we usually associate with chronic diseases that get you into the nursing home, which in some ways might be a silver lining of this whole craziness, is that we are starting to understand the microvasculature better. I usually use the metaphor that, imagine that you're sitting in your shower at home and nothing's coming out of your shower head, and you call a plumber, and the plumber shows up and actually digs up your water main in your front yard and tells you there's nothing wrong. Well, you'd probably fire that plumber. Well, the problem is medicine is still out in the yard digging up your water main when the issues are inside the house. And so in that sense, that's where we're going, is understanding how to actually help the small vessels, because the big vessels are in a sense solved.
I have a question for you. You treat a lot of patients, and I'm going to make a blanket statement. I'm going to say that most everybody has either had COVID or been vaccinated, and some both. Are you seeing a difference between those that were vaccinated and those that just had COVID? And are you seeing more people going to that have had the COVID shot versus those that have just had COVID? Are you seeing differences?
So they have on the coagulation part, they are very similar, I would say. Not, but when we talk about things like heart failure, neurological issues, autoimmune issues, again, we take care of all those too. It seems that the people that have been vaccinated are the ones that more likely have those issues than the person that just had COVID and wasn't vaccinated, that has much more primary microvascular disease that is more easily treatable. Does that make sense? So but that again is just an observation of my patient cohort. Even though it's large, it's still it encompasses a certain subset of people. So people that are seeking treatment, people that are that recognize that something's wrong. So I will tell you, historically, again, as I was treating COVID, as pulling people out of the hospital, getting them on home oxygen, keeping them alive, the world talks. And so there was a lot, people just started showing up after they had been hospitalized and hadn't gotten better. And that's when we started instituting a lot of what Jaco was already researching in South Africa, to say, let's try this and see if we can get you better from post-COVID issues. The other thing was, a lot of these people were very young. And so they had this kind of, oh, there is a marked change between how I was before or after COVID, or before or after the shot. There are a lot of people in their 60s and 70s that it's much easier for them or their physicians to rationalize that they are just getting older, or they are just missing a step. And the reality is, there's a lot more of that than I think we admit. And when we actually institute treatments in some of these people, the outcomes are very similar to getting back to being able to think, not having to go to assisted living, those kind of things. So there's a huge, again, we're talking about 2,500 people, but it's fascinating to see that the answer isn't always you're just old and out of shape.
So I had somebody that talked to me that was vaccinated. I believe she went for her second vaccine, and then an autoimmune response happened in her body, so that she wouldn't take any more of the shots. So what you're saying is that the COVID shot could actually trigger those autoimmune, and because she had attributed to the shot itself.
Yeah.
And that is a real.
Yeah. And again, that it's not unique to any vaccination. Our immune systems, as I think we were talking even before this started, is our immune systems are incredibly complex. I would actually argue that immunology is kind of one of the last bastions of medicine. The more I kind of compare it to a hall that we think that we'll get past this next door and we'll actually know everything, and we get to the next door and open it up and the room's bigger than the room before. The more complexity there is, the more we're able to get deeper, the more complex it becomes. And so anytime we poke the bear, imagine that your immune system is a bear. You want it to roar when you need it to, but when you poke it inappropriately, it often roars and causes dysfunction in the immune system. The other thing is, a lot of these people were vaccinated that already had dysfunctional immune systems. And the worst thing you can do is poke a bear that's already awake.
Now, I know some folks that are still continuing. I mean, obviously, it seems like the COVID shot is now like the flu shot. It's becoming seasonal in that's how I'm perceiving it. And people are getting 5, 6, and they think that they're fine and there's no side effects. And other people, stop after 2, as I said, because of that. And then I've known people that have had mastinary coronaries and died within 48 hours of the shot. So it runs the gamut. We have a campaign that says that shot is safe and effective. So knowing that for some people it probably is maybe safe and effective, and for others it's deadly. That's what I've seen across the gambit in just the small amount of people that I see. You've seen a lot more people. What is your opinion of this shot, this COVID shot, and why is it safe and effective?
So I think when we say safe and effective, I think that's because they say it is. It is not necessarily that the science bores that out. Again, the original placebo-controlled trial has not borne out what it actually said it would do, and all of the other data has been what we call, it's really post hoc. It's observational, meaning it's happened after the fact. And you can, when we talk about standards of evaluating something in a randomized, randomized placebo-controlled trial, that data doesn't seem to have borne out. That 95% efficacy rate that they quoted, I would probably agree that everybody in here knows that that is not true. But again, trials are not the exact same thing as what happens in the real world. But when there's that big of discrepancy, usually a product starts being questioned, and I think that's the thing that I think the public health world has had to deal with, is that most people now know that what they've been told, especially the word effective, is not true. So even if they believe it is safe, I don't find many people that find it effective, at least effective beyond a month or two. But even that is an issue. Safety is also the other thing. Is it's hard to look at the data. The data in the VAERS database is overwhelmingly different than any other vaccine we've ever actually pushed on people or brought into the marketplace. Now, there's plenty of ways to rationalize why that is, and that's what you get from the public health officials. Of course, they like the data when it shows there's no complaints. They hate the data when it shows there's a ton. They use it for them when it's in their favor. They use it against, when it's not. But the other thing you're bringing up, and what a lot of our research has shown, is that the people that have underlying issues that make that vaccine dangerous for them, it's not something that most physicians or even I know exactly what to test before you would even give that vaccine. And so that makes it where, if it's safe and effective, but there's a certain subset of people that shouldn't get it, we should know that before we tell everybody to get it. We should actually have a warning saying people that, have sensitivity to this or have a coagulation issue, they should avoid the vaccine. The other thing is vaccines are not all created equal. And so there are different types of vaccines. And that is one of the things that's bothered me the most, is they wrapped this new injection technology in the word vaccine. And vaccines are different in terms of the mechanisms in which they elicit the immune system. And a lot of the historical vaccines that we have are passive, and passive meaning your body interfaces with a foreign antigen and your body makes an immune response. This is the first vaccine that we have that's been marketed that actually utilizes your cell to make a foreign pathogen. And in that case, it is a completely different vaccine. We have never co-opted the cell to make foreign proteins. Instead, we have exposed the body to foreign proteins to make immune responses. I will say the one vaccine that is probably the lowest in terms of side effects and serious adverse events is the Novavax. The Novavax is a passive protein subunit vaccine. It is interesting that our government has done nothing to promote that as a safer alternative to the mRNA injections. But there's many reasons that I could postulate why. But I will tell you that the Novavax is probably the only thing that I would ever even consider actually somebody getting.
Representative Belcher.
Thank you, Madam Chair. And thank you again for being here to answer all these questions. So we're the COVID vaccine efficacy, COVID response efficacy committee. So we're looking at efficacy or the effectiveness of the government actions. The very first question we ask ourselves when we're trying to determine efficacy is, what was the point? Efficacious at what? So there's been two justifications offered for the recommendation of these vaccines. The first justification, which I think has been pretty thoroughly blown out of the water at this point, both by your testimony, our state epidemiologist testimony, and others, was that these vaccines will prevent the spread of COVID. Obviously, that's not correct. Everybody's got COVID, vaccinated or not. The other justification that was offered was that the vaccine effectively reduces morbidity and mortality to COVID-19 infection. So my question is, how do you feel about that second justification? Is it correct across all the demographics for which we recommend it? And if not, is it correct for any demographic?
Well, I would say in the original trial, that was not an endpoint that they actually, it was not a primary endpoint. So to, after the fact, come up with a new primary endpoint, the FDA usually requires you to do another trial instead of just assuming that it's true from post hoc or observational data, and that has not been done. So again, they can argue that all they want with data that they may accumulate among, again, cohorts of patients within health systems, but the actual data doesn't bore that out because that was never tested.
We heard in this committee that there were 2 trials being done, and I forget the groups. I think one was the FDA, and I'm not sure if the other one was the CDC or not. But we also saw testimony that the data wasn't panning out the way they had hoped on one of the trials, and so they opted to change over to the other trial. So instead of having 2 separate data points in 2 separate trials, they both conducted the same trial to get to so that it wouldn't show negative.
Yeah.
Did you hear anything about that or see anything regarding those trials, or?
There's some suggestions as well as legal filings that there was some fraudulent stuff. I can't really comment on that, knowing that I don't have all the information, but it is not that uncommon in this world that, again, pharmaceutical trials are an interesting endeavor, and they're going to want the outcome to a lot of times be what they want it to be. And I hate to say that, but when we classically think of who gets, again, looking at the original vaccine trial that Pfizer did, 40,000 patients, 20,000 getting an intervention, 20,000 not. The intervention trial had, 5 cardiovascular events resulting in death versus the placebo had 1. Now, they said that those people had heart attacks for other reasons, and it wasn't one of the things that they were evaluating. It wasn't statistically significant. But to me, that is significant when you only have a certain number of deaths anyway. The other thing is you got to realize is you're talking about in that 40,000 person trial, you're talking about 218 something. You'll have to look it up, but it's a little bit over 200 cases of COVID. And that's how they came up with that number of 95%. That seems like a fairly small, subset of people actually getting COVID. And it'd be interesting if they did. Let's say if they did the trial right now, I think it would be quite different. Does that make sense?
Representative Belcher?
Thank you, Madam Chair. And to switch topic a little bit, same vaccine topic, but a little bit of a different area. I have heard, and I believe other members of this committee have heard, and through our study, we have found the suggestion that those who have received multiple doses of the mRNA vaccine products may then go on to produce something called IgG4.
Yeah. Which,
to my understanding, and not an expert, has the effect of an immunosuppressant. Is there any reason that could be accurate?
Yeah, so there's a couple things. One is you do, so it would be more of the concept of immune tolerance. And usually the metaphor people use is the beekeeper that when he gets stung by a bee doesn't have a severe reaction because he's been stung by a bee so many times. Okay. That's a good kind of concept to think about what IgG4 means. So it's basically your immunological signal to say, hey, we've seen this before. Don't overreact. Let it be. When we're talking about a pathogen that I just told you causes fibrin to form in an abnormal way and causes endothelial damage. The last thing you want your body to do is let that thing be and let it do whatever it wants. So immune tolerance in this case is very dangerous. The other interesting thing is the paper that came out about 12 months ago, the Novavax, again, I'm not advocating for Novavax here, but the Novavax didn't do that. So it seems to be something unique to the actual mechanism of delivery, the mRNA. But that suggestion in a normal time would have halted the probably halted the rollout and probably had them pull the thing off the market until they could figure out what the heck was going on. That's how concerning something like that should be.
Follow up?
Thank you. That's very interesting. And to follow up on that same line of thought, if there are some people producing this IgG4 as a result of these vaccines, is what they are producing going to be necessarily specific to COVID infection, or is there any possibility that it could result in a reduced immune response to other pathogens as well?
I would say the answer to that is we don't know. Usually immunological responses are specific to specific viral proteins. I will say the interesting thing about COVID is it does seem to affect the immune system in ways, the spike protein, in ways that cause immune tolerance / immune compromised states more than we've ever seen of any other virus. And you probably have seen that in a lot of your friends or people you say, hey, I used to never get, a bad cold, but now it takes me out in a sense. You get something that used to be, something that would last a day or two now goes into your chest and lasts 2 weeks. But we're seeing a lot more of that. The other thing is the uptick in a lot of these other things. I think there's a CDC, again, quoting the CDC, but the CDC having atypical pneumonia or walking pneumonia or pneumonia infections in children right now is kind of out of control. It's very different than they've seen in the past. And I think, again, it's just speculation and it's, a correlation, but it seems that these outbreaks of things are, again, happening faster, quicker, and just the health or the immune system of people in general is being compromised by the vaccine, but also just COVID in general.
Representative Wary?
Thank you, Madam Chair. Dr. Vaughn, as we learned more about COVID and who was more susceptible to the effects of it, we initially there was a perception that maybe older populations could catch it. As more data became available, we learned that really the patients who were dying had multiple comorbidities associated with this. And so kind of two questions. How does that play into the premise of this being more of a vascular disease versus a respiratory disease? And then the second is, in talking with colleagues of yours and physicians, how soon did the physician population understand the demographics that were really most detrimental for catching COVID and most susceptible and vulnerable to the disease?
Yeah, so interesting. I mean, some of the things that actually COVID or the spike protein actually elicits in the immune system are not good if you are diabetic, if you're overweight. There's certain things, like one of the things that we look at a lot is called interleukin 6. And interleukin 6, a lot of it's a cytokine that is very powerful and causes, in a sense, what you would call the cytokine storm thing that everybody would talk about. You would have this kind of aggressive issue. Well, interleukin 6 is stored in fat cells, a lot of it. And so those people were more likely to secrete tons of interleukin 6. When we talk about the microvasculature in people with diabetes and other vascular diseases is already compromised. So if you have more damage and more issues in those areas, you're going to, basically propagate and further the issue to begin with. So and looking at most of the data, I mean, there was almost the comorbidities in people that were hospitalized were, almost always present.
Representative Belcher.
Thank you, Madam Chair. And to take advantage of your wide-ranging expertise in treating both COVID and vaccine injured, I would like to ask about children in particular. Now, in our state, we received testimony from our leading epidemiologist that there were severe illnesses in children at some unspecified rate, especially, I believe he mentioned inflammation disorder that came along with COVID. If you look at our official statistics, I believe we unfortunately had one child pass away as a result of COVID. And if you look at the VAERS data for our state, if I'm not mistaken, I believe, and of course it's an imperfect data set, but it implies that we may have had several children die after or as a result of vaccination. So my question would be, can you tell us anything about the rates of severe illness that we're seeing in children as a result of COVID, and also the consequences that we're seeing as a result of vaccination?
So on the, kids that had severe COVID front, I mean, I probably the only people that I had to put home oxygen on were patients that probably one was 16, one was 17. Both of them had underlying hematological disorders to begin with, things that they were born with that made them more susceptible to having issues. They did fine once we got them on the right things. But yes, it was not an issue. In my acute clinic, kids were not really, even up until Omicron, I would argue that kids really didn't get COVID that much. It was very, very hard for them to get it. I don't have lots of different theories for that. Omicron was kind of the game changer. All of a sudden, kids did get it. But in my long COVID / vaccine injury, I see a lot of children. And so I go from not seeing anybody in the acute world to seeing lots of people that have residual issues. And usually these children, again, the associations that we see are a lot of mast cell activation. Mast cells are an immune cell that lives in our tissue, interfaces with the environment. So it's in our eyes, nasopharynx, oropharynx, GI tract, skin. It's also perivascular around the vessel. So these people were already hypersensitive to things historically. They're the typical kid that, very picky eater, but they're also, a lot of them are hypermobile. So, I mean, and we can go in some deep kind of pathophysiology if you want to understand how that's happening, but they're also very athletic historically. A lot of them are big cross-country runners, big cheerleaders, big dancers or gymnasts, and they've been devastated, and they've devastated by the vaccine or just COVID. I would say it's probably, again, luckily in my state, very few children were actually vaccinated, which I actually think of as a win for us. But it's amazing to me how many of these kids have been affected by COVID and the vaccine in the long term, meaning not,
Follow up.
Thank you. And thank you very much for that. And based on that, our state, as of right now, and as I've said, we received testimony that our state has not developed independently vaccine guidance, but we have deferred to federal guidance in a rather official capacity. As it stands right now, I believe the DHHS website for children's vaccines will direct parents to the CDC website that does advise parents to get their children vaccinated with the mRNA COVID vaccine. What would your recommendation be to our public health professionals regarding that particular guidance?
I would say use the data, use better judgment, and from any kid that I see, avoid at all cost.
Representative Polizov.
Um, uh, Thank you, Madam Chair. I have a question about diabetes. We received uh, testimony from our state epidemiologist that allegedly COVID is associated or like in some cases causing diabetes. Did you hear anything about it?
Yeah, there was a recent study looking at that. It seems like after COVID, that people are more likely to develop diabetes. Interestingly enough, I think a lot of the world's understanding of diabetes always focuses around insulin and the pancreas. But the reality is, a lot of what goes on when we talk about diabetes is more of what we call insulin sensitivity and metabolic disorder or metabolic dysfunction. And so, again, going back to, again, I'm biased because this is the area I research. But when you damage the microvasculature and the endothelium and cause issues out in the periphery, a lot of these people do develop, basically insulin has to get out to the tissues to actually cause sugar to be uptake by the cell. And if it can't do that very effectively, you all of a sudden have elevated glucose levels, your pancreas starts to make more insulin, and you get basically an insulin sensitivity issue, which we would classically call type 2 diabetes.
Representative Wary.
So if you're seeing this, I'm just curious, how are you treating this? If this is, if you're seeing this more common, I assume this is on the rise, then something we can expect.
Yes. And so some of the things that actually are interesting, and when we look at, there's a paper not too long ago, and one of the things the actual NIH did in their RECOVER trial was utilize metformin. They were surprised to find that metformin actually prevented long COVID, and it actually is a treatment for long COVID. But again, going back to I'm not surprised, is because you're actually intervening on the dysfunction that develops. And so if you help the body, a metformin is a biguanide that is probably a common drug all of y'all probably heard before, but it basically sensitizes your body to be able to utilize insulin more effectively. And so again, keeping your sugar levels down while you have COVID, not damaging the vasculature and damaging other things, you should actually probably not have as dire of consequences after you have COVID. So we use a lot of things that are metabolically mediated. I use a lot of SGLT2 inhibitors, which are things like Jardiance and Farxiga, in treating people with long COVID who have what we call post or vaccine injury as well, post-exertional malaise. Post-exertional malaise is the concept of after somebody elicits energy, they don't necessarily pay for it right then, but the next day they're completely exhausted. And in my research group, what we attribute that to is microvascular, what we call localized tissue hypoxia, meaning instead of when you go work out at the gym and you're pumping iron, your muscle says, hey, we might want to break down and get stronger. Instead, in this instance, the muscle says, we don't have any oxygen, we're angry, releases signals that say we need help, and you actually get an inflammatory response. And that's a lot of what we would describe as post-exertional malaise.
Representative Polizov.
On a different topic, you mentioned how different countries responded differently, and if we think like what our government should do in future, if there will be a future pandemic, like one question is like, should we look at what other countries doing, but also like it can lead us to a wrong path because every country had different way of approaching statistics, in the US, often it was PCR tests that were giving false positives, and people were over. The number of COVID was overinflated, but in some countries it was the way around. Like Germany had different type of statistics, and like if we say like, oh, China welded people inside the buildings and now they don't have any deaths for a week, like let's do what China does. But if their numbers are fake, Like, how can we compare with other countries, and if there any way we can do this comparison better?
So first thing I think of when I think of kind of an emergency response like this is the last thing you want to do is dictate from above what everybody needs to do. Because a lot of times the solutions are going to be from the people on the front lines figuring out what works and what doesn't, and actually allowing them to go with their curious nature and their ingenuity to find solutions. The problem is again, going back to that, what hospitals do well is they safely do things we know how to do, if that makes sense. And when we're talking about a new virus, a new pandemic, the last thing you want to do is hold the hand, tie the hands of a physician on his ability to try things and change from things that aren't working. And instead, was the response. They actually scared the physicians. In a couple ways, they scared the physicians from even taking care of patients, which is like telling a fireman that the fire's too hot, all right? Which is crazy. You don't need a fireman that's scared of fire. They also hamstrung the physicians and said, no, this is our formulary. This is the treatment that you have to do, despite the fact that it wasn't working. That is just almost the definition of insanity. And in fact, most of the places where they were allowed to try things had better outcomes. And those outcomes were because if you allow physicians to utilize their knowledge base to solve problems locally, a lot of times those local problem solvings create ideas and theories that lead to larger structures of treating people. I mean, the first person to do a coronary bypass didn't roll that out to every hospital. He had to try it a couple times, and then the actual technique and the procedures of doing that developed over time to where you can do it on any hospital anywhere in New Hampshire. In this is the way we're going to treat it from day one without the knowledge of actually how to treat it, which is just asinine. Instead, what we need is to empower physicians, empower free thinkers, empower curious people to get their hands on the disease and learn how to treat it. The other thing is waiting for a savior, like the vaccine was supposedly the savior, is the worst way to approach head-on a pandemic. And even Dr. Redfield, who's a friend of mine, would say, we are spending too much time focusing on a vaccine. We should be focusing on therapeutics that actually are antiviral, anti-inflammatory, and prevent death. These vaccines don't prevent infection. And so from that standpoint, why are we spending so much time on that? I mean, since 2022, monoclonal antibodies were pulled off the market, maybe because they thought they had won, meaning like, oh, everybody's had COVID, it's over, it's behind us. But no, COVID's still with us. It's damaging a lot of people. And the solution damages a lot of people too right now, which is the vaccine that they have offered up. Where are we on developing good therapeutics for treating diseases?
Representative Belcher.
Thank you, Madam Chair. So, obviously, COVID is now endemic. It's with us, probably always going to be with us. We've heard testimony that it is the natural course of a virus, and we received testimony that this is true of COVID, that over the course of time, it naturally will tend to become less pathogenic, less harmful. Is there a cause to believe that the initial strain of COVID truly had a catastrophic mortality rate and that it just simply evolved rapidly into something far safer? Or is it more likely that the initial reports of a 5, 6, 7% mortality rate were just extraordinarily overblown?
Yeah, well, I think that it's your latter. I mean, even Jay Bhattacharya in San Marin County or Santa Clara County, and I mean, just proved, he just did an antibody study, which, by the way, should have been the first thing anybody had done, and just showed you the prevalence of it. And what they found was it was, again, point, there's already a significant amount of people within the county that had COVID. And this was, spring of 2020. And so when you actually add in those statistics, the mortality rate comes back down to, it's still probably at that time more deadly than the flu, but it was not anywhere near the 5 to 6% that was quoted. Because again, if your denominator only includes cases that have been diagnosed, that's a very, I thought we got past that 100 years ago in medicine.
I have a couple of questions, and one of them was on the Novavax that you keep that you've said a couple times that could treat COVID. When was that available? Because that is not mRNA technology.
Yeah. So it was available at the same time, actually. I guess what I will say is just knowing Dr. Redfield, talking to him at the time that he was in the room where it happened, he and Dr. Birx were overruled. They wanted to go down the protein subunit vaccine, and Tony Fauci and Peter Marks wanted to go down the mRNA route. But again, it has been available. There was some in terms of being able to get it at a large scale. Both of these actual products had never been produced in large vats, meaning they were all, small studies. Even the mechanisms and how they make mRNA for the vaccine study was through a PCR process versus when they actually rolled it out to the rest of the country, they utilized what we call a batched E. coli process. They actually used organisms to make it. So even it was a different in kind, even compared to what was actually in the study. They actually, in the regulatory documents, call it manufacturing process 1, manufacturing process 2. Most people got manufacturing process 2, which was not the way they processed or made the mRNA for the study. The Novavax was again, the protein subunit vaccine is a much older technology. And so it was much more, again, you're still being exposed to the spike protein, but your body's not becoming a factory for it. But it has been available. It was not the white knighted government's preferred shot.
Representative Belcher.
Thank you, Madam Chair. And on that topic, with the existence of pre-existing tested technology versus new technology, and the particular individuals who were championing which, and I certainly don't intend to sit here and guess at the keys to anyone's heart or attempt to indict anybody at all, but do you feel that there is a problem that some of the people involved with championing the mRNA technology were members of a branch of government that simultaneously held part of the patent for that technology and may have stood to profit from it?
Yeah, there was definitely a self-benefit to having a technology that was actually more held by, and actually, as we see the royalties roll into the NIH in the last year, which I found fascinating. I think they had $300 million, I think, the last year. Of course, there's about 280 scientists at the NIH. So, I've heard that New Hampshire, they don't pay y'all. Well, maybe you need to become a scientist at the NIH and you might get some royalties that, but that, we're talking over $1 million if every scientist got, we're talking about something, $400 million is not chump change. The other thing is, I think what I would call the medical industrial complex, the relationship that industry has with our regulatory authority. Again, it wasn't until the 90s to speed up drug approval that the actual budget of a lot of these studies that the FDA required could be financed by pharmaceutical companies. And so 70% of the FDA's budget is provided by licensing fees and other things. And if you have that kind of budgetary involvement, then you're going to have a lot more sway. And I think that is one of the big issues that we have in government, what I'd say the NIH, FDA right now. The other thing that was interesting, and this actually came up when I was speaking before the House Judiciary Committee was it was interesting to find the person that testified with me, Philip Kraus, was one of the lead scientists with CBER, which is the biologics and basically they approved biologic things. So meaning they approved biologics, blood products, and vaccines. And he was in that summer of 2021 was being pushed to license the vaccine. And in his testimony, he says that the reason that he was being pushed and told by Peter Marks was because we need to license it so we can mandate it. Well, the problem is that is not a scientific way to license something. You don't license something because you need it mandated. You license something because you say it is safe and effective based on the standards that you have set forth for the people that you represent as a regulatory authority. Now, he was removed from his post, and Peter Marks took over his position, and he approved the vaccine. Of course, Peter Marks went on to have 40 YouTube videos promoting the vaccine. Interestingly enough, the FDA is not involved in the promotion of products. In fact, it's not what they should be doing. They are not an arm of industry to advertise. They are a regulatory authority holding industry to account and safety for the citizens. So the fact to have that FDA person involved in approval, and actually Thomas Massey during that hearing played Peter Marks's videos. And it's just so antithetical to the way that we think about regulatory authorities.
Representative Polozov.
Could we go deeper into incentives and how a physician can be free of it and what different plays in it? You mentioned federal legislation that was focusing on certain treatments and putting some monetary incentivization for it. When we talk to our state government, they often say that they are not involved with setting up treatment protocols for hospitals, that there's certain associations, medical associations that advise hospitals how to treat patients. But we also know, so there are some incentives from federal legislation. Then I don't know if it's always a middleman, but there are some insurance companies working for government insurances or otherwise who maybe put some incentives for doctors and hospitals to treat in certain way. So how does it work and how your practice is able to be more flexible in what you do?
So first thing is, yes, I mean, it's probably the argument to say, well, how something gets reimbursed won't dictate how we treat. And that's just being foolish. The honest truth is most of these, especially in the American medical system, these are the profit incentive. There is, a lot of the times just even treating COVID patients at the time that the rest of the hospital had to be shut down. These hospital administrators, as well as the middle managers, were just trying to find a way, and so trust me, they read over the CARES Act. The CARES Act also involved a lot of direct funding to these hospital systems. But in addition, they found that the incentivizing of taking care of COVID patients was quite to their advantage. Now, in the end, at the time that they made those recommendations, we're talking April of 2020. So I don't know that the recommendations at the time, meaning not the recommendations, the legislation, were necessarily had we figured out that this was the wrong thing to do. But the worst thing you can do is codify a treatment based on payment before you even know how to treat it. But that's the last thing I would do. The other thing is empowering one of the things I did again was trying to find a way of taking care of healthy people with chronic conditions in my clinic. But at the same time, I did not believe that telling a patient that was sick that wait until they can't breathe and go to the hospital was the best way to treat somebody. And so what I said was, we've got to find an effective way to do this within my clinics. And so I had drive up testing, but when these patients would test positive, they would be able to come into a part of the clinic that they could get treatment, including monoclonal antibodies, the same day that they were diagnosed positive. Okay. And so my outcomes were incredible. We probably treated over 20,000 people and, had 2 deaths among those people. And you're talking, again, that's more statistically in line with what you would expect. But it was the fact that we had to set up a system to understand, how do we assess who's positive, who needs treatment, and then how do we follow up with them? So again, going back to the coagulation issue, on a lot of those people, I would have them come back 6 days later, get a D-dimer, get a chest x-ray, and actually learn that if I implemented anticoagulation day 6, they didn't go to the hospital day 11 and 14. And so again, that was just learning as you go where the signals are and where to intervene. But when you tell all of society physicians that they can't see somebody until day 14, you're missing the most important days to determine what the heck works. And so again, goes back to, and you can see this probably in the physicians, the media reports of physicians dying and the physicians dying in China. I'm not really sure what the motive was at the time, but they scared the hell out of physicians, and they scared the older ones especially. And I think a lot of times that had a deleterious effect to the patients needing treatment when physicians were scared to even touch the patient.
Follow up.
Follow-up. What's the situation currently with monoclonal antibodies? You said something about them being removed. I remember Florida was championing this treatment, but then government kind of nationalized it and said it will be centrally distributed. Is this treatment now not available at all? Or?
Yes. So there are some still available monoclonal antibodies for specific reasons. They're very expensive. But they actually kind of turned off the spigot on monoclonal antibodies in April of 2022, I think, which was kind of surprising. The interesting thing was, even that is an example of insanity. So our state, Alabama, was they actually were centrally given the monoclonal antibodies. So what I had to do as a owner, as well as an advocate for my patients, is get to know the legislators really well to find out who the heck is the state pharmacist, and then find out where the heck these monoclonal antibodies are. Okay. Now, most doctors aren't going to do that. I'm a little crazy. Great. But it was interesting to find out I was actively treating patients day 1 of positive test, having great outcomes, while a lot of the big hospitals had hundreds, if not thousands of these doses, and they hadn't used them because they weren't useful day 14. So what did I have to do is get the legislator involved to get me to get the monoclonal doses from the hospital, because the hospital had no interest in treating people day 1. And I don't blame them. They were taking care of the people day 14. But you know what? They really complained a lot about all these sick people. Well, there's a solution. How about give the monoclonal antibodies to me to get people treated so they don't overwhelm your hospital? But that's not a solution that they ever thought of. So as a solution that I had to come, I had employees driving 4 hours to go to some random hospital in South Alabama that didn't even know they had 100 doses. Is that just to show you again how this kind of top-down approach, spread it all out equally, has its consequences.
Follow up.
So follow up on my previous question. So what allows you to be that flexible? Are you not taking Medicaid and Medicaid and other insurances, or are you under different type of licensing? What allows you this flexibility?
So I am my own boss. Effectively, the patients are my boss. I own my own pharmacies. I own my own clinics. I own my own buildings. I know, again, this isn't the idea for everybody, but at that point, there wasn't anybody that said, no, you can't do that. And there is freedom of curiosity in settings that you're allowed to help. And so it was kind of a calling to say, no one else is doing what I think should be done, so why not do it? But a lot of doctors in the current world aren't their own boss. I mean, actually, my father, a physician in the 70s and 80s, they were, for the most part, they were private group practices. Most of them paid their own kind of way, paid their own salaries. They worked with hospitals, but at the end of the day, when there was a disagreement between the hospital and the doctor, it was because the patient wasn't taken care of correctly. Now, when there's a disagreement between the doctor and the doctor gets fired by the hospital. The patient doesn't benefit. And that's the problem, is we have taken the ability of physicians to be curious and also actively be involved in what they think is best for their patient, which is really the foundation of medicine.
Representative Wary?
Thank you, Madam Chair. Dr. Vaughn, the discussion about treating patients finally at day 14 reminded me of a couple of things. I saw some studies where they attempted to treat patients with ivermectin or hydroxychloroquine, but the problem was those patients were too far progressed in the disease. They were, died a few days afterwards, and so there was no. It was what I would call, and I have had about 40 years in the pharmaceutical medical device industry, so I'm somewhat familiar with this. I thought it was a poorly designed study because you're treating patients who are too far gone. So I'd like to get your comments on that, and then kind of a second aspect is that I think these studies were also used to then state that hydroxychloroquine or ivermectin were not useful, and we've found out since then government agencies have actually reversed that position. But I had people telling me that these drugs were actually dangerous, where having traveled to India several times, I was taking hydroxychloroquine as an antimalarial, and it's one of the safest drugs around. And so I was really confounded by the publicity that was getting out there versus good science. So if you could, I know that's a lot to unpack, but if you could comment on that.
So the first thing is, yes, they were not poorly designed. They were intentionally designed. And they were intentionally, you can design a study to make your product look like it works, but you can easily design a study that shows you a product doesn't work. And actually that's what you'll find throughout, unfortunately, pharmaceutical trials. And there's a lot of even pharmaceutical trials that are, backdoor sponsored in some ways by the competitor to utilize the cheaper option or the more, the safer option to prove its inferiority to whatever product might be, higher up, meaning more reimbursable, more new, more patentable. The interesting thing, and this is, again, I guess my background as a chemical engineer allowed me to understand this, is medicines are molecules or natural occurring substances that act on mammalian cells, things that matter to us. That does not limit them from acting on other mammals' cells as well. The other thing is, just because they're approved for one mechanism of action does not mean they are no longer to have other mechanisms of action. In fact, by definition, most medicines have something called side effects that half the time are dependent on the fact that they have other mechanisms of actions that cause issues. Okay? Again, this is just basic, but again, we're talking about a world that is acting completely crazy. Hydroxychloroquine, approved in the 70s in my Harrison's textbook of medicine as an antiviral. Antiviral. Now, again, does it have efficacy in COVID? You are correct that the trials for it were designed inappropriately. The other thing is, in the summer of 2021, the data that they used for the big JAMA and Lancet study didn't actually exist. And it actually took some sleuths on the internet to prove that there was something called Surgisphere, which was this guy in Chicago that had a female escort as the head of it was like, once you did a little background to look and see this data set and see the origin of this data set didn't come from anywhere legit. But the Lancet and New England Journal were so committed to their biases that they wanted that data to be true, even though it accounted for more people than actually live in Australia. Like and they all had to issue an apology. But the problem is when you're looking as a scientist, when you're looking, and I have to check myself all the time, when I'm looking for something that corresponds and basically, confirms my biases, I like that, meaning I want to promote it. But that's where medicine exposed itself. And so again, that retraction of the dangers of hydroxychloroquine, no one ever published the retraction. That data that was pushed out in the summer of 2021 is still assumed to be legitimate, even though the Lancet and New England Journal, probably one of the bigger scandals that they've had in a long time, and they had to retract things, but the retraction's never covered. Same thing with things like ivermectin. Ivermectin is one of the safer medicines we've ever found. In fact, I'd probably argue that half the stuff on a over-the-counter pharmacy shelf is way more dangerous than ivermectin. But it, again, provided relief. It provided people the opportunity or the possibility of treatment. And I think that was what the train that was rolling toward the vaccine didn't want in its pathway, which was an alternative possibility of something that effectively treats the condition.
Follow up.
Yeah, if I may just comment on that briefly, is that you're right. If there is an alternative treatment, then you don't get emergency use authorization. And so if any of these things were to have been found even moderately effective, no emergency use authorization would have been approved, would have facilitated the distribution of the vaccine.
Yep.
I have so many questions. Where to start? So I guess a basic question would be, is we have heard testimony in this committee that people felt like their voices were squelched, that differing opinions from the medical community were not getting out there to be heard in regard to treatment, so that there could have been options. And just in listening to what Representative Wary said, that if there were options, then emergency use, couldn't have been utilized. How was your voice? Was your voice being squelched at any time during the pandemic?
Yeah, I mean, again, at least in the state of Alabama, it was, again, the Medical Association of the state of Alabama, the state health officer are all kind of in their own world, and they were following, probably as your state does, whatever the CDC or the federal authorities say, or in all honesty, probably whoever gave them money. But it's just, in general. But yeah, I mean, I was called down. I had other physicians turn me in, physicians I'd never met, and physicians that would write letters saying he is spreading, lies by saying the vaccine doesn't present infection. Well, by the time I got down to the board, pretty much everything I was turned in for was actually correct. But at the time, it just shows you how even within the confines of medicine, there is that there's tattletaling and backbiting and those kind of things. The other thing that I found interesting was, that all of these people I didn't understand their point of doing what they were doing because it didn't make sense. Didn't make sense to spend time to turn somebody else in that was having success and helping people. Does that make sense? Like, it's just very, you know. But the one thing I will say is the other thing that gives me the freedom to do this is because I have the resources. So, getting a letter from the board and then having lawyers, defend you, it's not necessarily cheap. I have the resources to do it. I probably have more law firms on retainer than I know what to do with, unfortunately. But for a guy like me, I guess they picked the wrong person because I was not scared. I was not squelched by fear. It was just like, well, I'm going to have to spend, $50,000, $100,000. Not, it's worth it. Let's go. And I think that mentality, especially if you're a private practitioner out independently, you don't have a $50,000 sitting around to defend yourself. Instead, you're like, let me just shut up. I got to feed my family. I got to pay my mortgage. And so there is that. It goes back to why I have that freedom to do it is because I also know that, I, again, pay my own bills, but also have the resources to make sure that I'm defended appropriately. Because, the other thing that I was turned in for was I went to my own child's board meeting, school board meeting. He was becoming a kindergartner. My wife loved this, obviously, because it was, I think he had just started kindergarten that Friday and the board meeting was Monday. And of course, I get up there and tell them what my thoughts in terms of, the fact that this is, regardless of what let's, basically on a lot of times I try to debate not necessarily, whether they're efficacious at getting people, keeping people from being infected. Mine was an argument of what do we not know? And it can't be good to actually mask children during their, most, developmental times of both language, nonverbal cues, their ability to interact with other kids and their teacher, having the teacher hug them. I mean, I'm elementary school. I mean, like your teacher is a big part of your life. She's like, literally, my kid's teacher can say something and what I said doesn't even matter. I mean, but I was two infectious disease physicians at the end got up and said the opposite. And one of them, thankfully the other one didn't because I have a little more respect for him. But the other infectious disease physician said, we know that there's no long-term consequences to children wearing masks, which just, again, the guy that's supposed to be up there with telling us about the science because he's an infectious disease doctor is the one that's really, spouting the stuff that's completely opinion-based and non-scientific. And so, but I did, call the Attorney General of our state and ask if I had given up my right to free speech. Again, I was there as a parent and a physician, obviously. A parent could make this argument. That's the other thing. It doesn't have to be, mask might not be good for my child. It's not and asked if I had given up my right to free speech when I became a licensed physician in the state. And evidently I hadn't, but evidently the board thought I might have because I was investigated for it,
Just based on what you just said, and only because we've heard testimony from parents, a statement you made was there was an infectious disease doctor that said masks didn't have long-term effects on children. As an infectious disease doctor, what was his area of expertise with masking in children to make that statement?
None. And that's the problem. But even then, expertise is not the issue anyway. I mean, I would say that no one, who knows, he could be correct. But I knew that no one had ever done that study because you couldn't even get masking children at school approved through an IRB because it's unethical. Like you couldn't have done that study before COVID because no one would allow it to happen. No IRB at any institute would say, hey, yeah, let's mask those kids for 6 months and see what happens. No, that's unethical.
So basically, there was no study done to make any blanket statements of anything.
Yeah.
in regards to studies, I think we touched upon this, and I'm not positive if we touched upon it here, but prior to COVID, there were studies done on masking where it showed that there was no difference between masking and the flu. And we knew that the micron of the COVID virus it wouldn't.
Yeah, it was air. It was
Thank
aerosol.
you.
It was not a droplet type disease.
Thank you. Representative Belcher.
Thank you, Madam Chair. And the timing is somewhat fortuitous here, as I was just a few moments ago made aware of a official report of findings from the United States House of Representatives Energy and Commerce Committee in a report on a particular messaging campaign around COVID-19 during the pandemic period. And one of the official findings of this U.S. House report is that the Department of Health and Human Services and public health officials made attempts to silence dissenting scientific opinions during the pandemic. So I'd just like to give you a chance to comment on that finding.
Yeah, again, I mean, that's antithetical to what, the basis and foundation of medicine or just science is. I mean, I think dissenting opinion is the core of, well, I mean, what I'd say is alternative opinion. It doesn't have to always be dissenting. But it's, I mean, it's an interesting world to live in when the truth is already decided.
Representative Polozov.
I have a question about spike protein getting into heart. Like COVID vaccine, as I understand it, it's supposed to be injected intramuscular, and I think the idea is that all the produced spike protein will stay in this compounded part of a muscle and won't go traveling around the body. So can you comment on it?
Yeah, we knew that to be true before, that it wouldn't stay in the muscle, and we know that to be true after. I mean, mRNA has been found in breast milk. mRNA has been found in heart muscle. mRNA has been found in ovary. I mean, you name the tissue.
Follow up.
Also, a testimony I received here in the House previously, and I confirmed it, that CDC has guidance on vaccine injection and on vaccines. It's called Pink Book. It's on CDC website, and somewhere in the middle of pandemic response, they changed the way vaccines are administered, and they said inject it quickly with no aspiration. I think the term is aspiration when you pull back to check if there's a blood, and that recommendation was based on some very small study in Canada with a very limited group that said that allegedly there's no difference if we inject quickly or slowly with aspiration or no aspiration, so let's inject quickly with no aspiration. But the argument for aspiration and slow injection was exactly not to rupture the tissue and not to limit the chance that vaccine will go into blood instead of muscle.
Yeah, I didn't know they had changed that, but yes, the reason that you aspirate typically is to make sure you're not in a vessel.
Representative Belcher.
Yes, just to clarify that on the record, we do have that, the change within this committee's records that was made not during COVID, but in some time immediately preceding COVID was made as an official recommendation, I believe, of a major nursing group based on the, what they said was that there had never been proper studies done demonstrating the efficacy of aspiration, so we should just go ahead and get rid of it.
Sounds about.
Representative Polozov.
It's a little bit personal, but just last week in my district in Dunbarton, New Hampshire, one constituent confided that he was injured by COVID vaccine and still have lingering issues. So I don't know if you can advise like are there any groups in New Hampshire that can help my constituents, especially that previously we heard that people with vaccine injuries sometimes they double victimized with their doctors because their doctor doesn't want to admit that the
Yeah.
person was injured by vaccine. So sometimes they're being denied further treatment or something, or they're being treated for something unrelated without recognizing the reasoning for their illness.
Two things. What I mean, one, the organizations like React 19 or FLCCCC. Again, I'm a fellow of the FLCCC, which is basically a consortium of physicians that, in some ways, have become people that question the orthodoxy. During COVID, we were definitely questioning the orthodoxy. But the other thing that I find just in my kind of taking care of the vaccine injured and the long COVID is sometimes just allowing them to know that you heard them, but also that they're harmed by this I mean, people will cry because they have been to 20 to 30 doctors that have told them the opposite. And I think that's just it reveals in some ways what medicine has become, unfortunately, very heartless. And it has lost its art. It has become and by art, I mean, practicing medicine is actually understanding and caring and in some sense loving the person in front of you and seeing that they have value. Public health statistics, protocols, those kind of things remove that. And I sometimes think it's intentional to create callous physicians and create, I guess in the end will be replaced by AI anyway, but meaning like where that there's no one understanding what's unique to them. But that's the hardest part for a lot of these people. The other hard part, and we had a webinar about it Wednesday, is them seeking compensation for their injuries is incredibly difficult because COVID vaccine was not covered under the vaccine harm program, the VCAP. So it is covered under a countermeasure program, and that countermeasure program is underfunded. I think at the time that they were last questioned under the House committee, there were 6 members of it. So we're talking about thousands of claims, and I think 8 total people have been paid out a total of $400,000 for the whole country. That is an injustice in my book, and it needs to be rectified. I think there's some things that they're doing at the federal level to do that, but it is even sadder when you realize that even the safety net for vaccine injured that was developed, even though it's inadequate, these people don't even have access to.
Representative Wary?
Thank you, Madam Chair. I'd like to, we understand you're from Alabama and that, is there any particular legislation or regulations within Alabama that allowed you to do what you did? I'm trying to look at it from the legislator's standpoint for a moment and say, okay, how can New Hampshire create this same sort of environment that allowed you to prosper and your patients to prosper? How can we create that within New Hampshire? And so do you have any thoughts on that at all?
So, Alabama is still not a very free state when it comes to things that occur within the hospital. I mean, it's kind of run by the medical board and the hospital association. We have a certificate of need for any kind of hospital bed that needs to be approved, which I think we need to get rid of. It limits the ability for private physicians to find ways to take care of their patients outside the auspice of the crazy bureaucratic infrastructure that is the hospital systems. It gives the hospital systems tons of power. But those are the things that I think allowing physicians and groups of physicians to form and thrive is really getting rid of the regulatory burden or yeah, I would say the regulatory burden of creating clinics, opening places for treatment. I mean, again, I was lucky I own my own buildings and had, had clinics that I could have bunches of people come in and get infused with monoclonal antibodies. And also had enough space that I could do it in a place that was, meaning it wasn't part of where the other people were. But that, if you were to say, hey, I'm going to go open a clinic to take care of these people, just the regulatory burden to do that would have been, 18 months or something like that. So you need to, especially on a pandemic time of thing. And I think they tried to do this initially. They allowed doctors to cross state borders. They did all this kind of stuff because they saw a need. They needed more people. But there's a lot more of that you can do, especially in a time of emergency. Almost taking the rails off in a good way, allowing people to prosper and figure out things and try things.
Along that lines, and you don't have to answer. Are you able to accept health insurance at your clinics?
Yeah. I mean, I'm the same. I mean, I am basically a classic primary care organization. So meaning it's, everything. We don't take Medicaid mainly because we don't see, classically pediatricians see children. So, there's a lot of, I'll say we probably don't take Medicaid because filling out the application probably takes more time than it's worth, meaning because that's just how many children we typically see. But Medicare and it was, basically approved by all, but even that, I actually have to hire somebody that's their full-time job is to credential my physicians and make sure that their, T's are crossed and their I's are dotted for every little insurance that exists. And that, again, that's why a lot of these places can't exist on their own because cash flow and those kind of things are hard. If you don't know how to do it and you don't have enough volume of scale, to hire somebody that literally their whole job is to make sure that doctors are signed up for insurance, that's how crazy the world has become.
And on the lines of Medicare, I'm just curious, did you have to follow any certain protocols at your practice in order to receive reimbursement during the pandemic?
I did not, because within that, there was an exception for office-based physicians, which thankfully that exception existed, because if it didn't, I would not be accepting Medicare.
Okay, right, because we saw that at our county nursing homes, where, so
The regulatory burden becomes more heavy. So again, going back to why was I able to do it is being able to be an office-based physician that didn't have to interface with all these regulatory things allows the freedom to treat patients, especially in a time of a pandemic, with innovative things.
And just in answer to Representative Ware's question, we do allow, and I know we were trying to pass, but we do allow concierge doctors now, or, practicing nurse practitioners, but right now they have to practice under a certain license, but I think we're trying to loosen that aspect. Representative Belcher.
Thank you, Madam Chair. Forgive me, I don't remember if this was discussed in our hearing now or just prior to it during casual conversation, but you mentioned that there was a fairly dramatic disparity in being able to receive funding for studies looking at COVID injury and long COVID versus vaccine injury.
Yeah.
And I know personally, as somebody who was vaccine injured, I've had multiple doctors, upon learning that I was a vaccine injury patient, have their demeanor drastically change and no longer wish to treat me. I've heard the same thing from other people in a similar position. So my question is, do you think that these things are linked and that there's any sort of official government actions or messaging or incentives that contributed to that kind of environment?
I don't know that there's an incentive structure in place. I feel like, again, I think y'all had Aaron Siri testify a couple of weeks ago, but one of the things he challenged me was, how much vaccine education did you get in med school? It's a very interesting question because there's not vaccine education in med school. There is, when do you give the vaccines education in med school? Which is, those are the questions. When, where, how often? Those aren't questions of the science or the efficacy or the safety, but instead it's already assumed that they're safe, effective, and people like you don't exist. So for a physician to have to confront that, that is not an easy thing for them to do, and they don't like to do it. They don't like to be wrong.
Representative Polozov.
Could you do you have any thoughts on a framework that is called science-based medicine? So today we talked about some problems with public health statistics and that research is sometimes biased and there are some conflicts of interest with research papers. And my understanding is if we are then take those biased research papers and centrally mandate those findings to every doctor despite their own observation. So maybe that's the problem with current approach, because in theory, science-based medicine sounds great because science is great, medicine is great, but if framework is flawed, so do you have any thoughts on how is there any underlying problems and other ways to fix it?
So I do think, I went through medical school in 2005 to 2009. And that was at the time that there was this conversion to what we would call evidence-based medicine. Evidence-based medicine is a fancy term that you'll probably hear a lot of physicians. That's not evidence-based, yada, yada, yada. It is useful for especially evaluating certain things. But it requires a lot of information, a lot of robust trials, that literally the only people that can afford things to prove on the randomized controlled trial versus placebo world are pharmaceutical industry or some type of government entity that has a lot of money. And so that means that if you were to boil everything down to evidence-based medicine, medicine becomes protocol-based and doesn't assess and doesn't care necessarily about the person that you're taking care of in front of you. I think evidence-based medicine informs you. It gives you help in understanding a disease process. It gives you help in understanding mechanisms of actions of medicines. It gives you understanding that, hey, this does have a therapeutic effect. It doesn't replace the fact that you're a physician taking care of a single individual, and that single individual is unique. And I think that is where that disconnect has happened. It requires, again, in my testimony in front of the judiciary, one of the things that I've always heard, you'll heard the word follow the science. And the problem is that it's not really a good term. Science isn't a leader. Science is an informer. Science is it records data. People lead. People should be informed by science in how they lead. But to follow science is a really stupid statement, because science itself doesn't make decisions, and it doesn't say that with this information you have to do this. Instead, it is just the information. It's the analysis of the data, and a leader, a human, somebody with skills to interpret it is the one that makes decisions. And so that's where That's where the whole missing of that is. Science isn't a leader. And in fact, when you let science lead, it's a crazy, crazy road.
Representative Belcher.
Thank you, Madam Chair. And I think with that statement, I think you've effectively put science in the box that I would agree where it should properly go. And to continue on that same line of thinking, because science is a tool of analysis and understanding, and not everybody has the ability to become an expert on everything. So they're going to rely on certain persons and institutions largely to authenticate the analysis and the science. So with that in mind, what is your feeling about the present health of our institutions and particularly those surrounding the peer review process?
So, if anything, the last 4 years have revealed that your, what I would say, medical, as well as you could associate public health. I like to separate them, but your medical infrastructure, the people that take care of you, it's broken. And I think the last 4 years exposed that, because when they were approached or affected by some new thing, the response was very inflexible. It was very callous. It was very not humane. And an organization usually kind of exposes itself when it's put under pressure. So as much as you see the signs that say this hospital system loves and whatever, during COVID, they didn't really act like that, did they? And the peer review process is just as, first of all, peer reviewers aren't paid. They usually do it from an academic ivory tower. The journals themselves are owned by multinational organizations that basically have huge revenue and profit. And for me to even get access to a typical journal, you have to be part of a university, which is what I have to do on the side to make sure that I have, library access to all these journals, because the actual knowledge is not even, sometimes it's not even published, but even when it is published, good luck getting your hands on it if you don't have an institutional sign-in. And then the other thing is the NIH is really responsible. I think this is, again, going back to how I look at medical schools now, a little has changed, where medical schools used to be state or private institutions that their charter was to prepare and teach physicians to take care of the citizens of their state. Most medical schools have turned into pre-employment programs for their multi-billion-dollar academic medical center. And instead of physicians being trained to take care of the citizens of the state, they are trained to be a system physician. And that really does take away their curiosity. But the other thing is the funding for all these institutions comes from one source for the most part. When you talk about how medical schools are ranked or academic institutes are ranked, it's based on NIH dollars. How much money do they have? I think UAB has something like $500 million a year. Well, I mean, as a businessman, I've dealt with banks before. And if your business's enterprise is based on somebody's financial commitment to you, you listen to that person if they want you to do something or if they want you not to do something. And I think that's what we have to realize is the money that is delved out from the federal government to these academic institutes is very powerful in shaping thought, response, and ability to think freely.
Follow up.
Yes, and along the same lines of thinking, the disparities that exist, say now from 20 years ago, as far as your smaller physicians group and your self-employed physicians versus your larger conglomerations, seems to have shifted rather dramatically. I think some of us might make an argument that the Affordable Care Act had the effect of increasing the regulatory burden on smaller practices, such that many wound up selling to largers. I would say that the COVID pandemic was a 1-2 punch for a lot of practices who likewise um, wound up having to sell to larger conglomerations. I've seen that personally. My own physician had to sell his practice up to a conglomerate. And the reason this is important to, I believe, this committee is that there is a function within the New Hampshire Constitution that requires this government to take action where necessary against monopoly and in favor of open free trade and availability. So I guess my question for you is, knowing what has happened, do you believe that we're at a point yet where state authorities or federal authorities might do well to take a good look at monopoly provisions of constitutions and law as it applies to the current healthcare environment?
Yeah, I mean, I think at my own state level, one of the things that I think is, when we talk about the power of different medical boards and those kind of things, I think some of the rules need to be, if you're a physician that works for the hospital, there are only so many seats that can be filled on that board. There needs to be independent physicians. So in terms of just your own physicians, whatever your board of medicine or whatever you have to have representation from, it needs to be less than half of that can be from people that are within government, like whether it's the VA or some academic medical center or some hospital system, like who pays your check? Because the problem is once they flood the boards for these hospital associations and medical associations, they follow the party line and they create exactly what you're talking about, a board that is self-interested. So that's one of the things that I think is important, and that has happened over time. Other thing that's happened is I think medical schools need to be teaching physicians how to run a practice. That's the other thing is a lot of these older physicians, the reason that they're selling to hospitals is because the people that are coming out of medical school, they don't know which way's up when it comes to a balance sheet. And so medical schools are responsible for preparing physicians to practice in the state that they're going to practice. And part of practicing is being able to exist as an entity, meaning have a clinic and have availability. If we make a bunch of doctors and none of them can open a clinic, it's not very useful. So that's another thing that I think is important. I think hospitals are being bought up. I think even in our own state, UAB just purchased all the Catholic hospitals. Now, literally, they're went from 6 different hospital systems to 2. There was no discussion about there being any kind of monopoly power there. And, less choice, less competition equals worse outcomes for patients. And I think that's true.
Just to go along with that, we just had a discussion in this committee, I believe it was 2 weeks ago or so, that power, politics, and money played a huge role in COVID. And the question is how do we get around that in the next pandemic so that different voices come to the table? Does it, just because you have a different idea or a different opinion doesn't mean you're dissenting, but as a physician and as an internist and someone who wants to look at all data, in your profession, would it be beneficial to have differing ideas and opinions around a table? Would you come up with a better solution? Whereas it looks like when it came to whether we did the mRNA or the Novavax, one factor was going to benefit monetarily. That's not really to me, that's pretty biased, but having different opinions.
Yeah, 2 things on that. One, even talking about Novavax and mRNA, there are other vaccines. There's attenuated vaccines that are available from India. There's a Covaxin. They're not available in the U.S. And interestingly enough, Tony Fauci was on TV talking to an Indian reporter from India, and He said, we don't need your vaccines. We've got the best. That's fine if he thinks that, but that's not, in a broader market, especially people that may at the time, if he really cared about vaccinating larger swaths of the population and he knew there was resistance to a new technology, as a public health person, you should want all comers if you believe in what you believe. But it showed his bias really quickly because, again, let's say this is assuming that the vaccines worked and there was 15% of the population that didn't want to get an mRNA vaccine because it was a new technology. Well, why are you rejecting India's or the European Union's vaccine that's live attenuated vaccine? It makes no sense. But that's what we did. So again, money, power, and politics. What was the other question I got off on?
During, we discussed that, during another pandemic, we didn't look like different voices were brought in.
Yeah, I do think that classically, when you think about medicine is very siloed. It's very specialized. There are very few people that understand the complexities of all the things that are going around on them. And in fact, they're systematically getting rid of them because they make them where, you don't get paid much to be somebody who thinks, you get paid to do. But it requires, multiple people, not just the experts that are the infectious disease doctors that have no understanding. They can't even run their own practice about anything that has to do with economics or running business or how that'll affect. I think you have to bring all players involved in every aspect of your decision. And I think the medical board also needs to, again, encourage physicians to try and be involved, not discourage them to do anything other than what we tell you. And so that sometimes that's just the leadership of the organizations themselves. But at the legislature standpoint, having a bunch of infectious disease doctors or some super specialists come in and talk about COVID really is not useful when we talk about what to do about it. If it is, how do we treat it? What medicines should we use? That's fine. That's his expertise. What you should do about it from a societal standpoint in terms of how we run businesses, if you're asking him that question, you're getting the worst answer available. And that's what we did.
I agree with you. I mean, we learned early on that how important an industrial hygienist would have been in regards to helping mitigate a lot of this. I never even knew that there was such a person out there. So it's the little things like that we're learning on this committee that I think can make a big impact in the future, knowing that there are other players that have different expertise in different areas, to say, hey, look, have you looked at this? Have you looked at that?
And if you look at even in the lay public, I mean, beyond what, in my world was healthcare delivery. Like, how do I take care of these patients, both on the chronic side, but how do I also get patients in early, figure out what's going on and get them treated? I mean, those are simple things but that wasn't even discussed, right? But additionally, I mean, people were solving things from air filtration there were engineers. I mean, there was a lot of downtime for a lot of smart people, and we kind of wasted it. They all probably, instead of inviting, solutions, we basically said, well, these guys know everything, and, we'll just wait for Lord Fauci to tell us what to do.
I think that, and as was discussed in this committee, that we created a lot of fear, but a lot of distrust, and we need to figure out how to build that trust back up with the public.
Yeah, I think there was a JAMA piece. Again, it's JAMA. So we're just talking about the peer review process, but the trust in your physician has dropped from 71% to 40% in 3 years. That is, to have that kind of drop, people trusting their own physician, 71% of people did that to 40%. And this was JAMA's own entities asking those questions. So they're going to try to be probably a little bit you just think they would be. That doesn't bode well for the health we have a lot of other problems. I mean, I think even currently with a lot of looking at metabolic disease, ultra processed foods, those kind of things. I mean, we need to look at how we're already being treated. And the other argument I'd have in terms of the consolidation of hospital systems, has it resulted in a healthier society? Or is people getting sicker? The more that the health systems become bought up, the pharmaceutical industry becomes more involved in the FDA, and the FDA, I mean, to me, the trend lines are all, I guess we could blame it on the American population, too, but it seems like the people that matter that you would hope are the people that are solving problems and making people healthier don't seem to be doing a good job.
I wouldn't disagree. But when we're talking about statistics, there was something that we talked about earlier, and I just had a question. When you're dealing with long COVID and vaccine injury, is there a correlation between long COVID and those that were vaccinated?
Yes.
Could you expound on that a little bit for me?
So there are plenty of people that know the time, date, and place that they got vaccinated and were different. And so they have this almost time, or they have this moment in time that they know. Long COVID seems to be more, developed after they got COVID. Even a lot of them didn't really have many viral symptoms, but 2 to 8 weeks later, started to notice they didn't think the same. They couldn't run like they thought they could. They have other palpitations. So it is interesting to find that the vaccine seems to be much more moment in time temporal versus the long COVID seems to be developing kind of in this a little bit more, it's not subtle. I mean, it's still pretty dynamic, but it's not associated with some temporal change. I try in my practice to make sure that I know their long COVID symptoms when they got long COVID, every time they got infected and every time they had a vaccine. It's almost like I wanted to come up with kind of an acronym in gynec or OB is looking at like pregnancies, delivery, like you have these, we need to have like a COVID-3 injection for, because it does matter. It's cumulative. So.
I guess, so I'm a numbers person, and I don't know, this would be very subjective on your part, but of the population that you're seeing with long COVID, what is the percentage that have long COVID that weren't vaccinated, and then those that have long COVID that were vaccinated? Is there?
It's about 15% have never been vaccinated.
And so 85% of long COVID.
Yeah.
Thank you. That's a pretty telling number.
And I will say, in my state, with the state, if you want to just look at statistics, a state that the vaccine uptake was probably less than 50 or less than 60%. That's way out of proportion. In a state that maybe had 85% of people, and you could say that but in a state like mine where vaccine uptake was much lower, to have that high of a rate means something.
Let me put out a question. Not sure how much longer. I don't know if you have a time limit that you have to leave. We can break for lunch, or we can just keep on going. It's your preference.
We can just keep on going, I guess. Yeah.
Okay. Representative Polozov.
Thank you, Madam Chair, and thank you for taking my other question. Are you aware about some new data about SV40, that some of those plasmids used in COVID vaccines had some gene sequence that can act as a cancer promoter, and if that an issue, is it an issue only for one specific manufacturer, or is it common for all mRNA vaccines? Do you know?
So SV40 is a common promoter sequence for them to actually make RNA and DNA. There's lots of debate on if it's actually something that has cancer or actually is able to assist even genetic changes to get up to the nucleus. It is another example because actually, until it was pointed out by Kevin McKernan, who's an actual big geneticist historically at MIT, that it existed. It wasn't part of the actual. It was not part of the filing. Like they were supposed to their licensing application. But once it was pointed out, they added it quickly and said, "Oh, we always knew it was there." Well, if you always knew it was there, why'd you leave it out? I think that it is concerning. It goes back to, again, it's not my area of expertise, but the manufacturing process that I talked about, that typically the manufacturing process for these things was on a very small batch using a pretty time-intensive process. But when you rolled it out to billions of doses, you had to change on the fly. And I'm not sure that they had perfected their process, and especially in getting rid of contaminants. As a chemical engineer, you know, it takes a long time to perfect.
Yeah,
You know.
Yes, in the 90s, I worked with Dr. Salk on a analogy for HIV using the polio approach that he used, and we did small cell culture batches to grow HIV, which we then inactivated and used Freud's adjuvant as a vaccine, as a prototype that he attempted that was unfortunately unsuccessful, but had I think it did a lot to further the science and the understanding of what HIV was doing in the population at that time. So it was good mechanisms for science. I actually did have a question with regard to natural immunity and COVID. What have you seen? So I myself, I'll just share a brief personal testimony, is that I had COVID. My oxygen levels went down. I had not been vaccinated and had to be hospitalized. I was in ICU for 9 days and hospital for 14 days, and fortunately was not put on a ventilator. And immediately after that, physicians were suggesting, "Oh, you should get vaccinated." And I said, "What happened to natural immunity?" And so, do you have some comments on that?
Two things. One, yeah, when physicians were saying that, and actually Thomas Massey's phone calls with some of the FDA people recently showed you they had no evidence on actually getting the vaccine after you had COVID. And in fact, to say that would be safe and effective is completely Russian roulette, meaning they had no data. You were actually excluded from the trial if you had previously had COVID, which makes sense if you're trying to do a trial. But the interesting thing, and this is really more inside baseball, just talking to Dr. Redfield, so up until really Omicron, I mean, I had a patient base of about 7,000 antibodies. I had the machine basically that Ortho Clinical makes that could tell me what your seropositivity and your serotiter was. And so I have my own reference lab, which again goes back to how interesting I am. But I maybe had one person that had, out of that 7,000, that had been reinfected. Maybe two. I mean, it was counting them on fingers. Okay. Which is one of the reasons that I started to question the orthodoxy even more, because that was not what was being told. People can get infected, their antibodies wane. No, when the antibodies wane, they doubled every 3 months. So it was like completely, it was like they were just stating something that was either they had never investigated or they knew was untrue. But then Omicron came along, and Omicron, that's a whole different story on probably how Omicron, anyway, still don't know totally about Omicron. It's just totally different lineage. It's nothing to do with previous SARS-CoV-2 infections, just appears out of nowhere in November of 2022. But it revealed not only kids got infected, but also everybody that had gotten COVID previously started getting infected. With so natural immunity in this, it does matter that you've had COVID, but one of the ways the spike protein was manipulated, and that could be something that you could discuss, but was they tried to make the spike protein in a way that it did not alert or activate your innate immune system. Okay. So your innate immune system is kind of like your alarm system for the body. And again, this comes from just kind of knowing what they were trying to do in the lab. And so when you downregulate that innate immune response, your alarm is shut off. And so your alarm system doesn't work well. And so it makes it really hard for the natural immune processes to actually work, your protective immune responses, which are a lot dependent on your innate immune system. So it's just a unique, and again, even how they glycosylated the spike, meaning like the sugars, and it makes it very hard for the body to find and get rid of. And Dr. Redfield will tell you about where the alanines are on each of that's beyond my expertise, but it's interesting how they changed up the domains that would have interacted and actually had an immune response.
Follow up.
Yeah, but so I'm almost shocked because as science, you don't know what the outcome for that will be. You can't know what the outcome for that would be. So you're putting something in that has no evidence to support a knowable long-term effect.
Yeah. And we still, I mean, again, that study didn't look at long-term effects. I think probably Aaron Siri probably gave you all a schooling on how long actually people follow up after vaccines. You know, it's not what we think.
You mentioned the Omicron, which is was a different variant of the SARS-2, and that a lot of people were contracting that had already had COVID. What made that variant different? And
well, when you think about natural immunity and then how a virus mutates over time, you know, the more likely it is to the virus that you had, the more likely you probably have immune, activity that can help you prevent from getting it. When you have something that has a totally different lineage, all bets are off. So
when you say totally different lineage,
meaning it had nothing to do with Alpha Delta Wuhan. It appeared, as y'all remember, it supposedly appeared in South Africa in November or October. There's an interesting paper, and again, I can give this to the committee, that the closest thing that SARS-CoV-2, in terms of they're able to run genetics and look at protein structure and how it interacts with different mammals. And the most recent thing that it appeared that it had interacted with was Mus muscularis, which is a lab mouse. And so meaning everything about it, that was the most recent species to interact with it, if that makes sense. So again, I'm not saying we know that for sure, but it was an interesting paper.
Representative Belcher.
Thank you, Madam Chair. And I caught a little something there I'd like to drill down on just to see if I'm understanding correctly, because it's thought I've had before. Obviously, the weight of the evidence would now suggest that the COVID-19 original strain was not a naturally occurring virus, but rather something that very much appears, again, the weight of the evidence, to have been developed at a Chinese military laboratory in Wuhan with the input and perhaps funding of the NIH through Intermediary EcoHealth Alliance, who has now been sanctioned by the federal government for withholding information. Are you suggesting now, based on some of this genetic analysis that was done, that there was a strain that came about sometime during the pandemic that was sufficiently genetically dissimilar to anything else that was out there at the time that it might suggest a secondary laboratory release?
So it's a possibility. I mean, the other thing that they stated around that time, you'll remember that they were saying it's probably in some HIV patient that never cleared the virus and made mutations. And I don't know if y'all probably didn't read the stuff the literature that, meaning because everyone they're still dumbfounded on like why a virus all of a sudden appears with no previous history to a previous. So, I mean, that is one of the possibilities that that something else was new. I mean, because it is new when you look at its relation to the previous virus.
Follow up.
Thank you, Madam Chair. And just to dispel for anybody who's watching, that may sound like a crazy question, but given the modern technology for things like gene editing, is it really that crazy to suggest that there could have been some secondary playing around with this virus at some point along the way?
Not at all. I mean, I think the more we learn about what labs are doing with gain of function, the more we need to crack down on it.
In response to your patients that maybe had the original COVID and then the Omicron, did you notice a difference in symptoms?
Oh yeah, yeah. I mean, the Omicron was definitely much more, at least at that time, and still is, less thrombogenic, less platelet activating. Symptoms seem to stay mostly in the oropharynx, so throat, and it did not cause the crazy chest X-ray changes that were associated with Delta.
Having had both, I noticed a huge difference between how my body was with one versus the other. That may explain, I think, why there was such a huge difference.
Yeah.
Thank you. Representative Polozov.
Thank you. Did you have any cases when you had to send your patients into, for example, hospital system, and did you have any input on follow-up treatments and any feedback and so?
So, yes. So, when we talk about home oxygen, the European Respiratory Society at that time had a article that was talking about what we call permissive hypoxemia, which is a fancy term for saying, typically in medicine, your SATs get in the 80s. We're scared. But interestingly enough, in COVID, it seems like these people could hang out in the 60s and 70s. And again, I'm not giving any medical advice here. I'm just kind of telling you. And but they would be fine, actually, as long as they would sit there. They were, what would happen though is eventually, if their lungs didn't recover, they would start to wear out. So work of breathing can be very tiring. And so if the work of breathing tired out, I did have to admit them, but we would admit them to a place that could do ECMO, because the last thing we want to do is beat up their lungs, because the lungs are the problem. So ECMO, was the primary therapy. Now it was a salvage therapy in the hospital realm, meaning after they'd beat the lungs up on the ventilator for 2 weeks, they'd throw them on ECMO. But I've seen a lot of patients that actually, that's why they survived, was ECMO. The other thing is interesting. A number of my patients that survived got AFib and they got put on a blood thinner. So it was almost like, thank God you got AFib while you're in the hospital, because you got the treatment that you needed to get, which is, again, these are just, stories from the people that I've taken care of. But yeah, there was two people like that. One passed away, and then the other one survived.
Now, one of the things that we talked about, and because you own a practice, is healthcare worker shortage. Are you seeing that in your practice?
Yeah. I mean, it's hard. It's hard to get good people. At the time also, it's hard to keep good people because some of the payment structures, and most of the hospital systems are currently paying for that right now, because they were doing out-of-state nursing, paying 3 times the labor costs that they, and now they're all like, we don't have any money. Well, you also stole all the people that I because you could pay him 3 times more because you were getting. So yes, it is an issue. Um, but it was interesting in my cohort. Again, I think this goes back to why having a family company, a small practice, is my employees. I kind of look at as my second family, and so well, my goal was to take care of them throughout all this, and that's what we did. And because I was willing to take care of them, I don't know because, but I think because I was willing to take care of them, they were willing to work and stay and help. So.
What in speaking with different people, and I just spoke with someone on Tuesday who was a first responder in the state, and she was either told because she wouldn't take the vaccine to either mandatory retirement or they would terminate her, fire her. And then also at our county levels, if because of the Medicaid, Medicare dollars, if you refused the vaccine, you were no longer employed.
Yeah.
And do you think, and so these people have gone on to other things in their lives, and I don't think are coming back into the healthcare system. Do you think that created part of our issues?
It didn't help. Um, it was interesting still, even if you look back at the OSHA mandate, the medical provider mandate, the HHS mandate that all came out in September 2021. The only one that I think held up, which is crazy in the Supreme Court, was the healthcare worker mandate, which I thought was ironic because wouldn't it be the healthcare workers, the doctors, and other people that might be able to make the best decisions for themselves on whether they need to be vaccinated or not? Again, these are people that defer to the experts, right? It was just funny that the OSHA part didn't hold up, and then I forgot what the other one was, but yeah, I mean, it's they attached it to your payment from Medicare if you were in a hospital system. I don't know if that's still law.
I don't think it is at the moment. I don't think it's one of the issues, but I know even at the county level, contractors or subcontractors couldn't
they
go
were.
in unless they were vaccinated.
Yeah.
So they're actually having trouble getting work done. So yeah. Is there any advice that you would impart to this committee as we look at what we can do better in the next pandemic? We know that the next pandemic will be different. The virus or whatever it is going to look different. In your professional opinion, what do you think should happen at the state levels to prevent so that we can do better next time, to make sure all stakeholders are at the table, that all voices are being heard, that biologicals are an option and it's not a one size fits all because we're all different?
Yeah, I think freeing up physicians to be able to do what they think is right, and if they get any pushback, making sure they are represented correctly, that they're doing the right thing. Meaning, if they get fired by the hospital, having avenues for that. The other thing is just, I think the structure of most of these health authorities was never evaluated because they never thought that a health authority would become the authoritarian monster that they became. And so there's a lot of states that didn't even know that the person in charge of whether you could open your restaurant was somebody you couldn't fire, and your legislators and governor couldn't do anything about either. And that is a recipe for disaster. So anybody with the authority to shut down your freedoms has to be held accountable in every way. So structuring it that way is just common sense.
Does anyone else have any questions? I'm sure we'll think of plenty. But Dr. Vaughn, I can't tell you how much I think we all appreciate you being here and the information that you have given us. Wow. And some of the data, I think it's important for us to hear this information and to get it out to our citizens so that they can understand that there are people that understand and are out there that know what's going on, especially in the terms of long COVID and vaccine injury. And maybe we can get more people in this state involved in that to give these people help. We've had parents in here testifying and showing us pictures of their children. It's horrific.
Yeah.
It's actually it's heartbreaking. So thank you again so much for being here. I appreciate it. And I'd like to recess us until 2 o'clock. Is that too long? I think 2 o'clock will be good. We'll recess until 2 o'clock and come back and maybe talk about the report a little bit. Oh, and another report that just came out. Okay. So we'll recess until 2 o'clock. Thank you. I am going to have to put us into recess for another half hour until 2:30, as other members have been delayed. So we will recess until 2:30. Thank you.
Good afternoon and welcome back to the COVID-19 Investigative Committee. You're probably surprised to see me in this chair, as I am. We're just opening it up while we wait for the rest of the members for a few more minutes. So if you'll hang with us, we will be back in session to discuss a couple reports. Thank you. So the Dr. Vaughn, runs a large private practice, oversees, I believe he said, about 200 other physicians, focusing largely on COVID, acute, long COVID, and also vaccine injuries and effects. And he has an awful lot of experience. I believe he said that they've treated cumulatively about 200,000 patients. Um, he's has a lot of experience beyond just I don't mean to say just being a doctor, but beyond being a physician, he's also has a degree in engineering. He is obviously a businessman, running all that. Um, and he's also has experience. He's testified before Congress. Uh, he's out of Alabama. Yep, down south. So it was a very nice bit of testimony. We actually most of it was just question and answer. We had an awful lot of questions about a whole broad range of subjects. And it was very, very interesting. Now, whether there was a lot of brand new material, I think a lot of it was sort of stuff we've at least tangentially heard from other people as well. But nonetheless, it was very interesting, very informative. Yeah, it was very good.
Chairman.
I am. Thank you.
Film star.
I don't know how much time you have, but I need to be out of here no later than 4.
That's fine. I believe, did Representative Belcher open the meeting?
He did.
Okay, thank you. Well, what are we discussing?
That's up to the chair.
I just assumed that you guys were discussing the report and,
No, we were waiting for you.
Waiting for our esteemed chair.
You didn't miss a thing.
shucks. Well, good afternoon, Representative Polozov.
Thank you, Madam Chair. Just to open the discussion, I think our report should cover different topics that we discussed before as priorities for our committee, like we were discussing effect on education, and and also, if possible, I think it would be nice to document again who were people testifying in front of our committee, and also, I don't know if it's possible, but if possible, to outline what documents were submitted for the record of the committee, so to have it listed in our final report.
I think that's good. Some of the documents, I mean, I don't think we can attach them, all of them to the report because I think it would be too many. Representative Polozov.
Yeah. Even not attaching, but just mentioning the nature of the document or name of a document, name of an article, or some executive order or something else that was submitted.
So did, I think you mentioned to me that the researcher sort of gave you a format for the outline for this sort of report?
Yes, and I can forward that off to everyone. She gave me like a memorandum and then an example of a report, and I can send that off to the entire committee. I'll do that right as we went before we leave tonight.
Yeah, I mean, usually they do exactly what you said, Representative. They say what our mission was, they say how many meetings we had, who the people were. I mean, we're gonna have our own website, right? So we can link to the website for a lot of the documentation. And if there's specific documentation you wanna call out, we can mention that. I think the challenge may be what you were just what categories we want to talk about within the report, because we heard an awful lot of information and some of it is within the purview of the state and others of it isn't. So I don't know. Representative Belcher said he had a couple of reports he wanted to discuss. Is that what you said?
Representative.
Sorry.
Thank you, Madam Chair. The ones I have seen so far, the part that we need to focus on is the findings of the committee, and then what are the recommendations of the committee. Those should not be really robust as per se. They should be more of a short narrative, succinctly said. And then at that point in time, you can go into what it is that you want, like you said, all the attachments and documentation that we went through. But I think key to it's going to be what are the findings we have? What you're going to call them bullet points. And then at that point in time, what are the recommendations? And I would like to have the committee focus on what are the key findings, not every finding, but the key ones that we all can agree on. And then what are the recommendations that we have based upon the findings?
I think one of the key findings that we found was in regards to a lot of the information that was filtered down to the state came from the federal government. And as we discussed, the state could only act on what they were being fed. The other thing is, and we discussed that a lot of fear was instilled into the populace. And what steps can the state take in the future to mitigate some of that because you're being bombarded on a day-to-day level. And I think that played a huge factor into the whole pandemic and turned families against family members and people against people. And we have to remember that we were all in this together. And even though we may have different opinions, doesn't mean one was right and one was wrong. But, and then, when we listened to the Honorable Betty Gay, she said, she had some different ideas, but bringing different ideas together to get to so everyone can understand everyone else's viewpoint. And maybe one is better, one is making more sense and one's not as rational, but to dismiss people is not really, people need to feel valued and heard.
I concur. I would say that a couple of things I've taken away, and you hit upon one of those, and that is the fact there was the federal government. A lot of the information came from the federal government. As a state, we don't have the resources to reinvent the wheel. So we have to take on face value what the federal government is providing for information. Secondly, I would say the issue comes down to is how much state control versus local control. And do we, at this point in time, have a very, very strong state control? Or do we somehow, again, the state becomes the vehicle to bring that information from the federal level down to local level? And that's the tension between the state control versus local control. And then the other part I would say is, you really hit upon the nail, it's the fear factor. And what ends up happening is, and this is not the state, when I say the state, it's us in this room right here. We had competing narratives. It became politicized. And it was like, my narrative is more correct than your narrative. No, my narrative is more correct than your narrative. So we had competing narratives that are out there, which, to your point, tore families apart, tore friendships apart, because people didn't know which narrative. So if I was going to look at it in hindsight, we should have all got together and had a narrative and not have competing narratives. So that's my take on it.
And thank you for saying that. And but that's what this committee is here for, right? Is to see, okay, this is what happened. We can do better next time. And next time, we don't know what the pandemic's going to be or how it's going to react. It's going to be completely different. So, but I think, I think we have to approach that and at least we in this committee are sitting down, recognizing some of the issues, and we can sit here and talk about them. And I think that hopefully the public can see that we can do that nicely. And doesn't mean one person's right and one person's wrong. And I think that's really important, Representative.
Yeah, I mean, I do too. So I was just sort of thinking about this because I've written a few of these reports and I'm not volunteering to write this one. But a lot of the findings can be like some really basic stuff. Like I think Tricia Tilley came in, she had a timeline, right? I think the timeline would be really helpful to have included in the report. And that way our findings don't have to be the list of events. And then, maybe we can build to some extent about that. But, one of our findings can be, unfortunately, through the course of the pandemic, the discourse became very polarized and polarizing. And, then a recommendation can be, I don't know how you solve that, but to really work harder on messaging that is not politicized and polarizing and more unified. I mean, that's sort of how you can break it up.
I mean, it's easy for us to say this now because we're sitting here
Right.
playing the quarter,
Right. But we can have that as a finding, and then we can, because I mean,
Yeah.
if I'm remembering, I watched the live stream from Dr. Chan, that was one of the things that he pointed to. So unfortunately, we haven't really had somebody here to present the Homeland Security report, but I'm sure there are some things in there that just when we're doing our report, it's going to sound familiar to us. So, but there must be other things that we can say.
Representative Wary, then Representative Merchant.
Yeah, just to comment, I think the point about conflicting narratives is good, but I think that it goes further than that, in that we were getting conflicting data, and so I think I think we're fairly rational people here in New Hampshire, and we tend to form good rational decisions. But I think when we were getting conflicting data and not kind of testing that and sourcing it out, I think that's what ultimately led to the conflicting narratives. That's my perception. I'm a chemical engineer. I've done a lot of process investigations where there's something messed up, and what invariably happens is someone has made an assumption about something, and they've marched off in that direction because of that. And until you stop everybody, slow them down, and get them to say, well, how did you know that was accurate? How are you assured that that data is correct? Then you can't really do a proper investigation. You can't make proper decisions following that. So your point is well taken, but I think it really goes deeper than that. And I think that's the challenge for New Hampshire in the future, is sorting out what is accurate data and what is not.
I totally agree with that. I would say that we were trying to build a plane while we're basically flying it. And it's a challenge. I look back in the Spanish flu, back in 1916, 17, 18. The same issues we have today, they had as well. And it comes back to the fear factor. It was, again, competing thoughts, back to competing data, what people thought was right versus wrong. Some cities did it one way, one city did it another way. It wasn't until after the dust settled, we go back and look at the data in hindsight. You said, okay, that prevailed and it made sense. That didn't. But when you're going through the air and you're trying to build a plane at the same time, it's hard to sort through the data. I don't disagree that there is competing data. And the question at that point in time is, how do we somehow, I think, take the competing data and not turn it into supporting our competing narratives? And that's where I think it came down to, is somehow as a state, and I don't know whether we can do this because we also have the federal government. So the federal government, we don't live in an isolation. So you have the federal government. Sometimes you could have competing narratives between the federal government and the state government and within the states. So what I'm trying to get to is, I think we did as best as we could. However, could we have done better? In some ways, yes. But I think that's what we want to talk about, the recommendations and the findings, is we had all this competing data, competing information, if you will. We had a society and people out there looking to say, which one do I believe? And that's so hard.
I agree. And the other thing is, well, we just had testimony this morning from Dr. Vaughn and then Representative Belcher, as we were discussing. Someone did a study, and prior to the pandemic, there was a 70% confidence rate in physicians. He then said it was down to 40%, but as we were speaking, Representative Belcher got a report that said it's at 31.7% people trust their doctors. And so we know that not only in the medical industry, but in government, we've lost the trust of the people. And we need to gain that trust back, because if there's another pandemic, it can't be helter-skelter. We need to make sure the people are going to trust what they're hearing.
And Chair Lady, sorry. I would say it's probably one of the most important takeaways from this is that how do we get the trust back of the voters, the citizens, and people in our state, because they look to us for guidance. And if they don't have that trust in us, then we don't have much to hang our hat on.
I 100% agree with you. Representative Belcher.
Thank you, Madam Chair. And on precisely that topic, One, as I mentioned, there was a couple reports I wanted to discuss. One of them came across earlier, and this was just released very recently. This is and I sent it out via email as well. This is a United States House of Representatives report of findings called "We Can Do This: An Assessment of the Department of Health and Human Services COVID-19 Public Health Campaign." And this is looking specifically at a messaging campaign that was undertaken at a cost of more than $20 million per month by the firm Fours Marsh Group on behalf of the Department of Health and Human Services. And there's quite a lot of findings. I don't expect you'll probably want to read the whole thing. It's 113 or something pages long. But there's some very interesting findings, and I'd be happy to discuss some of them in detail. But the thrust of it is that this report lays at the foot of this particular firm a messaging campaign to the public that was not keeping up with what was known scientifically at the time that the messaging was being done, and as a result caused a collapse in public confidence in the government's sort of role in this.
Representative Belcher, was that at the federal level or state level?
Yes, that was the federal level.
Federal level. Thank you.
I mean, I think as part of our findings, we really have to say that the pandemic caused panic. And, you know, we had agency person after agency person come in and just say, you know, what a difficult scenario it was for them. And they were really, they were really scrambling. You know, we were dealing with remote situation when I mean, now we take it for granted, but it didn't really exist at that time. And I mean, I think the agency people were really doing the best that they could do. But I think our findings have to reflect the atmosphere that existed, especially in the beginning of the pandemic. I think that's really important. But if I was going to have a recommendation, I would say that our public health, you know, system, we really have to, I mean, I think there was probably some standard operating procedures in place for a pandemic, something like this, but I think that our systems really need to be tuned up and upgraded so that in a situation like this, if it comes up again, we're not scrambling like crazy. I mean, I assume there are things in place, but hopefully they'll reanalyze their systems and we'll be better prepared the next time.
I mean, I agree, but I mean, I also think that, you know, in light of the fact, we need to recognize that depending on what area of public health they're in, you may need to bring in engineers or industrial hygienists. It's not just, you need to bring in other areas because they're only looking at one aspect of it. And there's many, many aspects of dealing with the pandemic. And I think it's important, you know, just with Dr. Chan being here last week, and I asked him about, you know, one of the things that we heard that could have helped mitigate things like almost immediately in schools and things was air filtration and ventilation. Well, yeah, we didn't have the money for that. Well, what is that? But it still would be, to me, that would be under public health because you're looking at mitigating a virus. But his department didn't really focus on that. According to what his testimony was, and correct me if I'm wrong, you know, so sometimes we need to bring in others so that they can look at the different areas.
I mean, I think that's great. That's one recommendation
Right.
that we say that the response to that. I mean, and this may even be in the Homeland Security report that unfortunately our agencies have worked in a sort of, they worked in a sort of a siloed fashion, and over time they may have come together, but any response to a pandemic really has to be an integrated one
Yeah.
that brings in stuff like what you were just saying and I mean, I think there was an attempt to do that, but they should like have systems in place to make sure they do it in the future. But funding, of course, is always really difficult.
Well, of course, funding is always difficult, and and the thing is, you know, no one in this state should take lightly what everybody in the departments were going through at the time of the pandemic, that they were working hard and had the best interests of the state in mind. I mean, we have to be thankful for that. So we all have to recognize that.
That's important
And
to
I,
put in the.
and I did. I wrote something up pretty quickly. I was just going through some things, and one of the things I said is the decision could not have been made lightly. But as most of us have lived through this in the state, we will remember that the fear was instituted in the population. We must remember that what we heard much testimony and do a look back at what happened. We realized that it was a difficult decision that the decision makers had to make. I mean, that is important.
I think it's really important as a top line message.
This would be in the introduction.
Because they were working really hard and doing the best they could do.
Exactly. I actually forwarded this to Representative Belcher and asked him, I said that I think that this here, talking about how we shut down and unknown and how we have to be thankful. And I even closed with, that we must look at, thank our people that were involved in this. I think it's really important to thank everybody.
I totally,
Representative
I
Murphy.
totally concur. I say that it's not just as a legislative body, there's the trust with the populace. There's also trust with the state agencies. And I think what you're hitting upon is the trust with state agencies, that we recognize the challenges they faced and the challenges that probably are going to come next time. So I commend you for wording it that way, because I think we need to be sure that they know we have our support. We appreciate what they've done. I agree with you.
I mean, to leave something like that out would be foolhardy.
Well, and it
In
would
my
just be
opinion.
wrong considering- I mean, there's
And I just go back to what I mentioned before. I don't know if you had a chance to read through it, and it goes with a pandemic, and that's the fear factor. It's when you have such unknown and you're living in a vacuum, you're trying to figure out what's right or wrong, and there's competing data, whatever's going on out there. It's extremely difficult to deal with people when they become emotional and irrational.
I agree with you.
well, or sick. I mean, people
Right.
are dying.
Right. So, but yeah, so does anyone else have anything? Representative Polozov.
Today, during the morning, we discussed briefly compensations to certain injured individuals. But we even earlier we discussed like New Hampshire, like as you know, like previously returned some fines to businesses issued during lockdowns, and I mean currently some states take measures on people who were probably needlessly fired for refusal of COVID vaccine mandated in their business, and those people receive compensations. But for example, for even though most people who received vaccine, they seem fine, we obviously have people who had severe vaccine reactions to the point of being handicapped or otherwise severely injured, and existing mechanism of compensation are often onerous and not working and overwhelmed with number of people. who want compensation. So maybe it would be prudent to include some recommendation into report as government is reacting to pandemic, that there needs to be some safety mechanisms, better safety mechanisms for people who are inadvertently injured by government actions.
Thank you, Representative Polozov. So from Dr. Vaughn this morning, he has just, I believe, received a grant in his state to do research on long COVID, which I think will benefit everybody, and the effects. And he's documenting. I guess it's just he's just getting the grant going. So knowing that that's going to be out there, I think will be extremely important to people not only in New Hampshire but throughout the country to understand what his findings are going to be and looking at that. But as far as compensation, Representative Polozov, I've seen some of the reports coming through, and they're in different states for people who have were fired or let go. A Blue Cross worker who was forced to leave his position because he refused the vaccine. And then there was another one working for BART that is being compensated. But I don't think those are individual cases that are being brought before. I don't know if that would happen in New Hampshire, only because we are an at-will state. And I can just tell you that on Tuesday, and I'm just going to say this for the committee so that everyone hears this, I met with a woman about a different topic, had no idea, for some reason I said, oh, I have a committee meeting on Friday, and told her what our committee was. She goes, oh, I was one of them. And I'm like, what do you mean? She goes, I was a first responder in the state. I was the top first responder in my area. They actually put radios in my personal vehicles. I was the first one they would call. And because I refused the vaccine, they said, you either do a mandatory retirement or we will fire you. And she had to find another source of income. But those are some of the stories that you're talking about, but we are an at-will state, just so you recognize that. Representative Belcher.
Thank you, Madam Chair. Yeah, when it comes to the vaccine issue, I do think obviously so much of it was federal. And because it was an item that was recommended by the state, I think there's a necessity to bring in what we know, which one of the most important things I think we've discovered at this point is that when it came to making recommendations for the vaccines, our state really, first of all, didn't seem to have access to any sort of detailed federal data that we may have heard about. And they were, for the most part, just taking federal and professional association evaluations and recommendations and guidance at face value, which seems to be what they did.
Representative Belcher, I hear what you're saying. The challenge, I think, as a clinician, when you're in the midst of an epidemic, is what data is out there that's going to support any recommendation. A lot of it comes from your colleagues. A lot of it comes from things you've heard worked in some other capacity. And it's very, very difficult. I mean, that's why we do double-blind studies. We do a lot of studies out there and we go through it. And we rely upon the data that comes through those studies to show us what works and what doesn't work. The challenge I think I would face is that if you don't have those studies and you're collecting the data going through the study, it's hard to differentiate and make that clinical judgment. So I hear what you're saying. I'm not disagreeing with you, but I'm just trying to explain that when you're in the midst of it all, it's very difficult to say, what's the real data that I can hang my hat on? And you take the recommendations because that's all you have until you come through beyond it. That's all.
Yes, thank you. And I think that's basically the point I was trying to make, is that we were taking the federal government's guidance that they were providing to us, and that's just what it was. We didn't develop our own recommendations based on our own studies or anything like that. We took the professional data that was available, and we went with that.
I want to be sure I'm agreeing with you, but I want to be sure why I'm agreeing with you at the same time. I think we actually on the same page on that one. So I want to say thank you. There is common ground out there.
There's always common ground. Sometimes we have the same goal, we just have different ways of getting there.
I've used that many times myself when I was on the board of pharmacy with a colleague of mine, and we would have very robust discussions. We agreed upon the end result. We totally disagreed upon the path to get there.
Well, I'm just trying to, sorry,
Go ahead.
I'm sorry, I didn't mean to
Please.
jump in. So I'm just trying to think about this in terms of like findings and then recommendations. So I don't know quite how you break it up, but a recommendation could be that our public health folks continue to try to figure out a way in their systems for response to pandemics, to try to find some space to analyze the data more independently if it's impossible before, I mean, unless it's impossible before issuing guidance. I mean, that's the kind of stuff that we can say that I think we can all agree on.
Right. I mean, so we all know what we've heard in this committee. I mean, the testimony is the testimony. And we've listened, had a chance to ask questions and discern, and then if we didn't think something was right, we can ask it again to get to the bottom of it. And so we have findings through that. We also, in listening to that, have been able to discern really some of the points that were, the trust, the fear, the not coming together. Those have been loud and clear. Those findings we can't dispute. And so we can approach this from findings, but we have to look at what we did positive. So we have to emphasize the positive and realize that our findings are after the fact, that this is now not living through the pandemic. So that's why in the beginning we have to recognize that. And so by way, no means should this be, people feel like this is a criticism, but this is going to be a tool going forward. And that's what I'm hoping, that it will be a tool. And then as we have data, we can give data of things that we've received, even if it was from the federal government or federal guidance, and say, look, this is what we found out from that was at the federal level. This is what the state was privy to, because unfortunately, it all went hand in hand. And as Representative Groto last week was talking about, we have a healthcare worker shortage. Well, and I agree, but also at the same time, we lost like this first responder and a lot of healthcare workers because of the mandates, and not only because of the mandates, and some of them were imposed because if you wanted to receive payment, like at the county nursing homes, you wouldn't receive payments if you didn't impose those mandates, and that was federal guidance and not state. So we have to distinguish between the two. Even though it affected us at the state level, we need to point out that why did it affect us at the state level? It wasn't through any fault of the state, it was through the federal government. And then the question becomes, what can we do as a state to try and mitigate that in the future? Or ask our congressional, do you understand where I'm going, right?
I totally concur with, and I understand where you're going. I'll go back to the comment you talked about before, being an any, what do you call it? Any will, as far as an employment is concerned. At will, thank you. And that's a tough one because, we really in this state take independence pretty seriously. So we don't want to infringe upon the independence of the business community. So that's a struggle too, is recognizing that there is going to be that issue between the state philosophy of independence and what that means to the worker. I'm not saying we're going to solve it, but it's recognizing that that is in fact an issue that's out there. So if you had the federal government coming back and saying this is what you have to do, it almost puts the employer at risk because they can't get the reimbursement. They have no choice. So you're raising a really good point.
Right, that there's an in. Earlier, Barbara, and that actually is why our committee came together, because there continues to be a lot of, how shall I say, disagreement on the way the various agencies played out and the systems played out. And that, I mean, that's why we're here, right?
Right.
Right. Because, and it's that disagreement. And then in the testimony that we had, I mean, you guys brought in a lot of folks that, they really had issues the way it played out. And that was part of what so we can talk about that. Anyway, that's why we're here. So anyways, I just wanted to reiterate that I really agreed with you, and that's the point. And I would say when we first started, when we first started this committee, we were probably like, it's going to be really hard to come to an agreement, but it's because, as you said, there's a lot of disagreement out there that's really unfortunate. And one of the things we're working toward is to try to sort of bring consensus on a few issues that I think we all can agree on. So,
Yeah.
we
And I would
come
say,
out well on the other end here.
and to follow up on that, President Abel, is the fact that this committee worked through a lot of challenges.
Yeah.
But at the end, we have come together. That in itself is quite an accomplishment. So I think we need to be sure that we don't lose sight of that within the report, to commend the people in this committee that, yes, we heard, we listened, but we actually pulled something together that I think we all can come to agreement on.
Yeah, and I mean, I think if we can agree that we're not going to throw a whole bunch of people under the bus, I mean, I don't want to crush them under the wheels. I think everybody did the best they can do. But that doesn't mean like, okay, DHHS, you really need to keep your eye on the situation with long COVID, or you really need to keep your eye on the situation on vaccines as they play out over the years. I mean, all that sort of thing.
So where are we with that kind of a recommendation? I'm concerned about long COVID and people. Do we need resources, financial resources, to help those people get through it? Do we need to find out how to ensure that they get the care they need, they don't get hit financially? Because if they are falling outside of the constraints of their insurance policy, whatever it's going to be, I think that's one of the things we could look at and saying, how do we ensure that the people that have long COVID have been impacted by the epidemic or pandemic, that they have the resources they need to get the care they need?
I'll let Representative Belcher speak to all of that.
Thank you. Well, first, I wanted to quickly agree with what was said before, that I think in the report where there is area for criticism, and I'm sure there will be some area for criticism, it's I think it would be best be levied at the level of the agency and branch, not at individuals. The point isn't going to be, we're not looking to indict or impeach people through a report. It's a matter of what could have been done better and how do we do better in the future. And I think that's the way to
Without
look at
throwing
it.
them under the bus.
Yeah.
Unfortunately, I'm going to have to leave now because I was going to try to get at 4 o'clock because my computer died. It's on the OR table. I'm going to try to rescue it and see if it needs a transmission. We'll see what's going to go on. So wish me well.
All right.
And
Well, thank you. So just really quickly
Sure.
before you leave, I mean, I'm jumping ahead. So the idea is somebody's going to be generating, or because do we have to get this in by November 1st?
I don't know.
I feel like We kind of do.
That's what it says.
But it doesn't say that in our charter.
Yeah.
I
Oh, does
just
it?
kind of told this
Oh,
speaker that that was kind of like
Oh.
the due date. But also, I just want to let Representative Belcher speak to long COVID because he can actually answer that question really quick.
thank you.
I'm sorry, can you just repeat the question? I need a refresher as to what it was.
The question I have is that it's now become evident that there are patients that came down with COVID that have what they call long COVID, and they're suffering the long-term effects of it. What I want to ensure that somehow in the insurance policies, the insurance department, whatever it's going to be, two things. One is that they can have access to their insurance and not have it carved out, and all of a sudden it's no longer covered. And then number two, that the state needs to, either with Medicaid, whatever it's going to be, Representative Belcher, that there's financial resources to be sure that we can get those patients the care they need. Because I think it's no fault of them. They came down with COVID, regardless of the reason for it being, but we need to be stewards of their care.
Yes, thank you. I would tend to agree. I think there's certainly room to look at what mechanisms are in place to, well, first of all, I think for the most part, under current law, there shouldn't be any way to cut them off from insurance. I think it's important to look at making sure that continues. And I think there's going to be some issues as to whether what degree certain things are state level versus federal level, but that could even involve potentially making a recommendation for a resolution to our federal delegation or something of that nature. So, yes.
Thank you.
I mean, we can also, in our recommendations, we can also say something like that needs more study and we weren't able to complete, because I've done that before. Like, one of the recommendations is we should look at this some more, they should look at that. And it's not something we would do, but somebody else could do.
Right, and just having Dr. Vaughn here talking about how he just got money from his grant from the state of Alabama to start looking into this because it is a real issue. And the other thing is to make sure that doctors themselves are recognizing that there is long COVID and that they really need to start documenting that and looking at it. And I think that's a real concern.
Concur. I want to say thank you.
To the OR.
Good luck to the OR. Thank you.
Good
Are we going
luck.
to try to meet once more, November 1st?
November 1st.
Okay, so will you be able to come? You can't, okay, all right. Oh. Go ahead.
I'll be thinking of you though.
Thank you. Have a great weekend. What I would like to do is try and circulate the report, Representative Belcher, before next Friday. If that's doable, I'd like to look at it and just peruse it, and that before you send it out to the entire committee, if you don't mind. I do want to send out the sample that Kristen just sent to me yesterday. I just got that yesterday. And have her, so that everyone can understand what a committee report looks like and what is involved in that. So I want to send that out to the entire committee. And we'll meet next. I have next Friday's meeting is scheduled at 10 a.m. And I don't know about anyone else, but this has been a true learning experience for me as.
Yeah, I mean, I can't say that I came to it with enthusiasm, but it's been and I've appreciated working with you guys. I don't think otherwise we would have been all working together, and it's been a real voyage of discovery. So I guess the only thing, I hope we can get the report in advance, because it's going to be, I would be uncomfortable voting on a report if I just have it that morning. And unfortunately, after November 5th, we're like, who knows where the elections will go.
Well-
Maybe we'll all be sitting here and maybe we won't.
Well, we're all in office until what, December 3rd?
Yeah, I guess that's right. But I do think we should try to wrap it up as soon as we can. And I just want to say, we'll see where the report works out. And if there are things we can't agree on, then there's some things we can't agree on. And I don't want to walk away from the experience with ill will if we just can't come to, there may be recommendations we agree with and recommendations we don't. And I think we'll do our best to all come together and we'll just, I mean, I haven't seen the draft report, but I guess I mean that from the heart. I don't want that to sort of disrupt our otherwise good working relationship.
It's okay to agree to disagree.
Yeah. Okay.
And I don't think that anyone on this committee should have ill will towards anyone else. I think that everyone's been respectful to each other, and hoping that that we all conducted ourselves in a manner becoming of representatives for the citizens of New Hampshire. And I think that is really what is important. And getting to know each other a little bit better as people is important. At the end of the day, we're all here to do what's best for the New Hampshire citizens. We may agree on some things and we may disagree on some things, but it's okay.
Yeah. Yeah. So we'll see. Try to wrap it up then for November 1st and then.
Yes.
I mean, honestly, God, this is an enormous subject, and I think we can only do the best we can do, right? And I think our recommendations, if a lot of them are just, we got to look at this more, we really have to be conscious of this, we have to be conscious of that, blah, blah, blah. I mean, there's nothing wrong with that, considering the breadth of the topic.
Correct. And we all have to realize that, this is something that we haven't seen in over 100 years.
And we're not
None of us are scientists sitting on this on this committee. Certainly not my area of expertise, although I have learned a lot. And I think we've had some good quality people in here testifying. All the departments have been very forthright in coming and talking with us, and I think that was a good thing. So
I just honestly don't know if I'll have time, but I think we should at least try to look a little bit at the Homeland Security report if we can. I don't know, Representative Belcher, if you have time, but it'd be interesting to just at least look at their executive summary and see where they came down on some of these issues. I wouldn't be surprised if there's some consensus with them on some of the things that we're saying. I mean, especially maybe messaging. I mean, maybe you guys have looked at it. I don't know.
I perused it a little bit. I'll probably do a little bit more over the weekend. I have some time this weekend, so but yeah.
Yeah, I mean, that could also give us some ideas. Yeah.
Representative Belcher.
I was just going to say, I haven't done a deep dive. I have looked it over in some degree. I think the biggest utility of that report is going to be when it comes to looking at a section of a report talking about stuff like integration of different levels of government and communications and stuff like that. I think that's where the most utility from that report's going to come.
Well, and then, if that, I mean, we've talked a little bit as that being part of our findings or recommendation, and then that would be a good corroboration for what we've agreed to or what we think. It's always good to have reinforcement.
Anyone else? No? Thank you for being here this afternoon. I appreciate it.
Of course, I think we're all just like juggling an awful lot of stuff, and we did the best we can here, so. Yeah, we did. It was big. It was big.
Yeah.
So.
Yeah,
We'll see where the report comes out. I mean, honestly, I just think we're all got to do the best we can do and recognize that that's what it is.
Okay.
We
All
hope we
right.
don't have to have another pandemic in the next couple of years.
That would be terrible. But anyways, I would like to thank everyone. Have a great weekend. It looks like it's going to be pretty nice, a little cool at night, but I think a nice weekend overall. So November 1st at 10 a.m. and we will be adjourned at 3:31. Thank you.